Kasih hitungan aja ya, kasih Q aja, 5, 4, 3, 2, 1, baru.
Siap, Dokter. Nanti saya yang hitung mundur, saya akan mulai sendiri.
Terus yang lain jangan lupa matiin pakai headset atau mati.
Siap. Ini semua kami sedang di mute. Nanti giliran nanti di belakang masing-masing presentator ada yang Greetings of peace to all of us. Welcome one, welcome all to this auspicious call, where knowledge reigns supreme and wisdom stands tall. With hearts open wide and minds ready to soar, let's embark together to learn and explore. In the realm of obstetric anesthesia, we convene to delve into depths where insights gleam. From dawn into dusk, in this virtual space, let's unravel mysteries with grace and embrace. First of all, allow me to introduce myself. I am Burhan, who will be hosting this special occasion. In welcoming the activities of the third Indonesian Scientific Meeting on Obstetric Anesthesia and Critical Care, which will be held on 1st to 6th July 2024 at the Jimbaran Convention Center, Intercontinental Hotel, Bali. The committee has collaborated with the Department of Anesthesiology and Intensive Care of Professor Dr. Ngurah General Hospital and Faculty of Medicine in Udayana University to organize 7 webinar series and 1 guest lecture, which can be followed online through the Bali Anesthesia YouTube channel link. Before we begin this guest lecture, allow me on behalf of the entire committee to express our warmest greeting to all of us who celebrate the Galungan and Kuningan. Rahajeng Rahina Galungan lan Kuningan. Dumogi Stata Poli Kerahayuan Sarang Sinamian. And please let me send our deepest gratitude to our sponsor, PT Akti Scientific, who have supported this guest lecture. On this occasion, we have invited 2 special speakers and 1 moderator to guide today's discussion. Good afternoon to our moderator, Dr. Sindri, and Professor Lauren Plante as our first speaker, and Dr. Sarah as our second speaker. Thank you for taking your time to participate and share your knowledge and your esteemed experience in this guest lecture. And to the participants, we invite you to submit questions through our comment section. The committee will try to answer as many possible as questions. And at the end of the guest lecture, the committee also has provided an attendance link that participants can use to obtain a certificate for this guest lecture. Without further ado, let me introduce the moderator who will lead today's discussion, Dr. Sindri. Dr. Sindri was born on 13 May 1984. She completed her undergraduate studies in 2002 and completed her anesthesiology and intensive care in 2016. And then she finished her subspecialty studies in the intensive care unit in 2023. She had also gone through as the observer in Christine Brown Adult Intensive Care Unit in King's College Hospital, London. And she is currently an intensive care consultant. So let's welcome Dr. Sindri as our moderator.
Thank you very much, Dr. Burhan, for your kind presentation of me. Hello, greetings, Rahajeng Galungan, Sarang Sami. I would like to welcome our very distinguished speakers. The first one is Professor Lauren Plante. Hello, welcome to Bali. Also, this is your second day. I really hope that you have a very enjoyable trip before you go to Malang. And the second one, hello, Dr. Sarah, my party friend. Welcome also to Bali. And we are very thrilled and we are very happy to welcome you here. We are very excited as well that you two are very expert in your field. The first one is Professor Lauren, especially as the first speaker. Here is the, I could not say short, it's quite long. It's about 5 pages, I guess, 5 pages of his curriculum vitae about his personal achievement. And I would like to say, this is a very interesting curriculum vitae. Actually, she is one of the a special person that could get dual specialty. The first one is the anesthesiology, and the second one is also of the OBGYN. So this is very interesting. So we could also have some perspective from Professor Lauren Plante. In this occasion as well, I would like to welcome my seniors and also my fellow colleagues from the Obstetric and Gynecology Department from RSUP Prof. Ngurah. Hello, sir, and hello, fellow colleagues. Thank you very much for also joining us here. This is a very late recognition, but I really hope that during this holiday, you could still make some benefits from this special guest lecture. Without further ado, I would like to welcome Professor Lauren Plante. She would tell us a little bit about what majors obstetric hemorrhage would come. Professor Lauren Plante would tell us about major obstetric hemorrhage. And to the IT division, who did, okay, it's already been seen, slides. So without further ado, Professor Lauren, please give us.
Thank you, Dr. Cindy.
Thank you.
So my apologies, friends and colleagues. I had prepared this as a standard lecture for 60 minutes, and Dr. Cindy threw me a curveball when I found out it was going to be 20 minutes. So I'm going to do my best New Yorker. I'm just going to talk fast. Okay, so let me just show you this slide here, and you're going to wonder what this has to do with obstetric hemorrhage. You all will recognize this building, right? This is the Taj Mahal. Do you know why the Taj Mahal was built? It was built by a Mughal emperor in the 17th century to honor his favorite wife, Mumtaz Mahal, who died in her 40s, giving birth to her 14th child after a 30-hour labor. So this is it's a beautiful building, but it's a monument to postpartum hemorrhage. Let me put some numbers here in perspective for you. Estimates are 14 million women per year worldwide develop a degree of obstetric hemorrhage. And it's anywhere up to 10% of all deliveries. In most reviews, it's probably the single largest cause of maternal deaths. And if you do the arithmetic, you'll see that while in the 2 hours that we will be doing this lecture, 20 women around the world will have died from postpartum hemorrhage. I thought this would be interesting to this particular group because this is an audit of maternal deaths specifically from 11 referral hospitals in 6 provinces in Indonesia. And some of you may in fact know more about this than I do. Some of you may have participated in this audit. But a thing I want you to see here is that of these 90 deaths that were peer-reviewed and audited, the authors, the committee, thought that preeclampsia accounted for 40%, right, of those deaths, and that postpartum hemorrhage accounted for 16%. But that's not the whole story, because if you look through here, this is bleeding, uterine rupture is bleeding, antepartum hemorrhage is bleeding, ectopic pregnancy is bleeding, uterine atony is bleeding, molar pregnancy might or might not be bleeding, and so what you're actually seeing here is not 16 deaths, not 14%, but 27 deaths, or about 30%. So if you wanted to make a difference in maternal mortality, you'd spend your efforts on preeclampsia, eclampsia, and hemorrhage. A couple of different definitions here, either more than 500 mLs or more than 1,000 mLs of blood loss at the time of delivery. And the most common etiologies, so we're mostly going to spend a lot of time on uterine atony because that's the most bang for your buck. Because if you can get control of uterine atony, you will have dealt with approximately 2/3 of postpartum hemorrhage cases. But we think of this as having 4 T's, right? Tone, trauma, tissue, thrombin. So tone, uterine atony, that's the big player. Trauma, so obstetric lacerations, uterine rupture. For tissue, we think placental problems, either retained placenta or an abnormally adherent placenta, such as an accreta. And then this is a small case. These thrombin, for thrombin, we think coagulopathy, acquired or inborn, but that's only under 2% of cases. So if you think back to poor Mumtaz Mahal, she had a number of risk factors for postpartum hemorrhage. She was over 40. She had more than 4 previous deliveries, and she had a prolonged labor. So I can show you all of these risk factors for postpartum hemorrhage, but what I need you to know is that 40% of women who have a postpartum hemorrhage will not have had any of these risk factors. So for all practical purposes, everyone is at risk. Quick lecture on physiology, and I am almost embarrassed to talk about this in front of an anesthesia group because You guys live and breathe physiology. But the things we know in pregnancy are blood volume, cardiac output, vasodilation, right? And then less at the forefront is clotting factors and the needs of the fetal placental unit. So again, every anesthesiologist I've ever met could say this stuff in their sleep, right? But the heart rate rises, the cardiac output bumps by as much as 50%. Mean arterial pressure drops, but it drops in the first and second trimester and rises again in the third trimester. Systemic vascular resistance drops. Your red cell volume increases, but your blood volume or plasma volume increases more. And so your hematocrit or your hemoglobin therefore drops, right? So normal hemoglobin in pregnancy is somewhere in the 11% range. It's important to remember that fibrinogen production is cranked up in pregnancy. And so a normal value is over 400 milligrams per deciliter or 4 grams per liter. And then most of your clotting factors increase. Take a minute and look at this slide, okay? Because this is uterine blood flow over time. Here's your uterine blood flow prior to pregnancy. It's about 50 mils per minute. Here's your uterine blood flow as the pregnancy progresses. So you can see by the end of it rises consistently through every week of pregnancy until you're at about 700 mil per minute at the end of pregnancy. So that's at least 10% of your augmented cardiac output going to the uterus and placenta. The other thing that the obstetricians in this group will be keenly aware of is that the pipes get bigger. The size of the uterine artery triples from the non-pregnant state up to the third trimester. So you've got bigger pipes and more fluid going through them. So you would think, honestly, that women just routinely ought to bleed to death at the time of delivery. And yet, fortunately, we don't. As a species, we have survived. And so there are some mechanisms that keep most of us alive, right? So hemostatic factors, particularly fibrinogen, but some others also increase. The fibrinolytic process drops, but most important is the contraction of the uterus after delivery of the placenta, which clamps down or tamponades those pumped up uterine arteries. This is my blood loss estimation slide. I don't know what you do here. Mostly we look over the drapes and we say, it's about 700. And it's not. The first thing they taught me in anesthesia school is you always double what the surgeon tells you is the estimate of blood loss. I don't know if they teach that here, but that was a lesson I learned early. So there are some objective methods for blood loss. You can weigh the swabs and the sponges. You can have the patient on a calibrated collection drape, which drains directly into your collection system. There is an expensive and not yet fully operational colorimetric analysis I'll show you in the next slide. And if you really wanted to know for sure, you take their post-op hematocrit and their pre-op hematocrit and divide that by their estimated blood loss. And 24 hours after the incident, you'd have a number, but of course that's not helpful at the time. This is the colorimetric analysis. So it's a smartphone app and artificial intelligence in which you hold up your damp or wet sponge, and it tells you roughly how much blood that corresponds to, and it totes it up for you over time. So all of you will be acquainted with the standard classification of hemorrhagic shock because we do it in AT, in advanced trauma life support, and you do it routinely as you're taking care of surgical patients. This isn't terribly helpful for OB patients, though, because the expanded plasma volume means that she can easily get to class 2 before she really shows you anything, before she shows you a narrowed pulse pressure or tachycardia or really much of anything. So I put this in because you're going to see it in every textbook, but it's not really so helpful for OB patients. The shock index, on the other hand, that probably is useful. It's a quick calculation that you can do at the bedside, and it does correlate pretty well with the need for transfusion. So it's the heart rate divided by systolic blood pressure. And the normal range is somewhere between 0.5 to 0.7. if your shock index is above 0.9, it's a good predictor for massive transfusions. So this slide here is a Japanese slide, which shows that the shock index doesn't change in people who have a normal amount of blood loss, but you can see that it does change as higher degrees of blood loss occur. You can see that the shock index can be seen to rise. And this slide here, I think, is useful. People with a normal shock index, so less than 0.7, they never needed a transfusion. By the time you got a little bit elevated, 0.7 to 0.9, you had about a 5% chance of needing a transfusion. But look here, once you got, approximately above 1, 25% chance. Once you got above about 1.5, 30% chance. Once you got to over 1.3, two times out of 3, she's going to need a significant transfusion. So this is, I think, a pretty nice and quick number to keep in mind. Okay, so you're looking over the drapes, or they're calling you to the ward because somebody thinks the patient is bleeding heavily. I put in, so what do you do about it? Well, I put in this non-pneumatic anti-shock garment because it is used in some places in Africa and Southeast Asia as a temporizing measure to get the patient to a higher level of care. We don't use it in the US, and so I'm included here only to be complete. Perhaps you have experience with it, but I can't say too much. Uterine balloon tamponade, we do a couple of these every week. This is a way to tamponade the uterus from within. So you insert this balloon into the uterus, fill it with fluid, okay, and it holds it compresses the uterine arteries from within. And there's a decent success rate with this. Somewhere above 85–90% will stop bleeding without a further intervention. The two pictures you see here, this is a commercial product. In the US, it's marketed by Bakri. It's a whole kit, but you can also just make one with a condom and a Foley catheter. We'll skip this, interest of time. So this was really being pushed pretty hard by the World Health Organization, particularly in Africa, until a couple of years ago, when suddenly they sort of retrenched the recommendations, because used as a standalone without moving the patient, without proper assessment or moving the patient to appropriate levels of care, it didn't reduce mortality. But if you are in a setting where it is your temporizing measure and you can get the patient to appropriate care, it in fact is pretty useful. I like this particular device, which also we are using. This is marketed in my country as a JADA, but it is the opposite of a balloon tamponade. So you insert it into the uterus and you connect it to vacuum, right? And so as you'll see on this slide, so here's a big uterus. Here's the device in the uterus. Once you connect it, you seal it at the cervix. You inflate this with 100 mLs of saline. And once you connect it to vacuum, you see the uterus contracts down. The thing I want the audience here to be aware of is that this device was actually trialed in Jakarta. That's where the first study came from. Since then, it's been used in a number of places, and it seems that probably it used in a real-world setting, you probably get good control of bleeding in about 3/4, and somewhere approximating 90% of people will not need a further intervention. So you put this in, it stays in place for an hour, 2 hours, and then you gradually take it out. And in most cases, if the issue is uterine atony, you've had a success. Temporizing measure, aortic compression, that's a very short-lived temporizing measure. Okay, so if you have to go to the OR, so either you're the surgeon or you're the anesthesiologist. The surgeon's job is identify what she's bleeding from, because if it's lacerations or trauma, that's a suture deficiency. That's not a coagulation problem. Is it uterine atony? Because then you have a couple of options there, uterine compression sutures or devascularization. Is it a coagulopathy? In which case the surgeon isn't really going to be able to help too much. Meanwhile, if you're the anesthesiologist, you are busy repleting the patient's blood volume, providing relevant drugs, which in many cases will be uterotonics, and keeping the patient stable from a hemodynamic and coagulation standpoint. I think we may not have too much time. There are a number of surgical techniques for postpartum hemorrhage. There are a whole bunch of uterine compression sutures. The best known is the B-Lynch. So it's a big suture over the fundus of the uterus. It sort of pulls the uterus down in a brace fashion. But you can also use something like hemostatic square sutures, which if you had a small area of morbidly adherent placenta, that would be helpful. These are all multiple different types of compression sutures which have been trialed. You can see that in some cases they can be paired with an intrauterine balloon. You can interrupt the blood flow to the uterus. So there is a bilateral uterine artery ligation, which is performed low. There is a ligation of the ovarian artery, which is performed high. These can be difficult to do, but they're easier than the hypogastric ligation, which is almost never performed in my country anymore. It is a technically difficult dissection with some extra morbidity. And so we don't do that. Aside from the fact that once you ligate the internal iliacs, you really don't have an option to embolize the uterine arteries, which is sometimes used as a treatment for hemorrhage. Here's your definitive treatment for uterine bleeding: no uterus, no bleeding. But it doesn't treat coagulopathy. An interesting thing to know is that as our rates of cesarean delivery have increased, our rates of cesarean hysterectomy or peripartum hysterectomy have also increased. These figures come from a busy practice in Texas, in which I want you to look at these three epochs. Here, the cesarean rate was 20%. Okay, rose to 32%. Okay, but you see that as the cesarean rate rose, you not only saw more cesarean hysterectomies, but the percentage of cesarean hysterectomies performed as a response to placenta accreta it's now more than half. So if your cesarean rate is rising like ours is, you too will see this. If you are not the surgeon, right? If you are not the surgeon, you are faced with volume replacement, which is fluids and blood, maybe uterotonics. Again, most of these are going to be uteronatomy. We used to think that the treatment for hemorrhage was to give people 4 times as much crystalloid as the blood they had lost. But more recently, we think some degree of hypotension is safer because massive infusion of crystalloid actually increases morbidity, right? And so an approach to hemostatic resuscitation would be you limit the volume of crystalloids, you replace your blood products early, and you implement a massive transfusion protocol when you are in dangerous territory. So just to show you here, the more fluid you gave a patient, right, the lower her fibrinogen got, the lower her platelet count got, and all her indices of coagulation get worse. Here also, you will see that as you have given more and more fluid, the percentage of women with an adverse outcome for hemorrhage really increased. So it may be that our classic strategy of just, give them back all the crystalloid you can find is not actually useful. The International Federation of Obstetrics and Gynecology has some recommendations for the treatment of postpartum hemorrhage. Again, bearing in mind, most of them are going to be uteronatomy. So start out with oxytocin, give them some crystalloid, don't give them too much crystalloid, give them tranexamic acid and uterine massage. For the 10 or 20% of women who have refractory postpartum hemorrhage who do not respond here, you are potentially dealing with balloon tamponade, aortic compression, maybe uterine artery embolization, and some kind of surgical intervention. Blood and blood products. So again, not knowing what you have and how easy it is, you are at a referral hospital, but in your more outlying or rural areas, they may not have all of this. So packed red cells, fresh frozen plasma, platelet concentrate. There is a fibrinogen concentrate available, and cryoprecipitate. We think of someone as having a massive transfusion either when we've had to give her more than 10 units of packed red blood cells within 24 hours, or we've had to replace her entire blood volume within 24 hours, or in 3 hours, we've replaced half her total blood volume. And if you have a massive transfusion protocol, then when you get to this range, there should be an automatic trigger in which your blood bank then begins to send you 1-to-1-to-1 ratio of packed red blood cells, fibrinogen concentrate or cryoprecipitate, fresh frozen plasma, and platelets. This is a sample massive transfusion protocol. If your own institution will have a massive transfusion protocol that makes sense for them. A concept we have not really begun to, but since we take a lot of our cues from the trauma literature, we might want to consider that maybe if we have profound hemorrhage and we have the accompanying hypoperfusion, acidosis, hypothermia, and coagulopathy, that maybe what we should do is keeping the patient alive. So with damage control resuscitation, it's a sort of a hypotensive resuscitation, massive transfusion, damage control surgery. So you whack out the uterus, pack the belly, and get out. And then in the next 24, 48 hours, when the patient is stable, you go back in and you finish the job. There are some thoughts about when you might consider this for a patient with massive postpartum hemorrhage. Are here, but again, at your own institution, you'll probably have your own protocols for how you would like this done. Not sure this is readable. Let me do this one. So standard. So you have some drugs available to you that can affect uterine tone. The classic one is oxytocin, which can be given IM or IV. It can be given as a slow IV push or over an infusion. The problem, it's cheap. The problem is that really you require change, and so there are places where that's not going to be so useful. There is a heat-stable formulation, carbetocin, which is 20 times more expensive, but does about the same thing. There are the ergot alkaloids, so methylorganovine, which also requires cold chain storage. And we don't give that to people who have hypertension or coronary artery disease because it can precipitate crises in these folks. Misoprostol is a synthetic prostaglandin, cheap as heck. You can give it PO, you can give it per rectum, you can give it in the vagina, although in a patient who's actively bleeding from the vagina, it tends to get washed away. You can give it rectally, or you can give it into the cheek. This is a useful and inexpensive drug to use. Having spent now 2 whole days in Bali, I don't know how well it does in the humidity, and I would be interested in knowing your experience here. And then there are some prostaglandins. There is an injectable prostaglandin F formulation, also requires cold storage. There is a prostaglandin E2. These have different side effects, and there are different contraindications to their use. In addition to oxytocics, you have some drugs that affect coagulation, specifically the antifibrinolytics. The best known of these is tranexamic acid, which by inhibiting the breakdown of fibrin will stabilize a clot. So 1 gram IV over 10 minutes. If she's still bleeding, 30 minutes later, you can give her another. And then your standard list of blood products, right? So fresh frozen plasma has fibrinogen and plasma proteins. You can estimate how much of an increase you'll get in coagulation factors. Cryoprecipitate has also a fair amount of fibrinogen, more than fresh frozen plasma. And of course, human fibrinogen concentrate has more than any of these. Massive transfusion protocols we have talked about. Let me skip this. I don't know if you have this available to you. So there is point of care coagulation testing in which you have a viscoelastic hemostatic assay. And so you have a measured amount of blood in a cup with a pin, and either the pin spins or the cup spins. And I'm sorry to put everybody to sleep, but this is a normal thromboelastogram. So the R value here is the reaction time. It's time from onset of the test to the initial fibrin formation. So it's the start of a clot. This is dependent on clotting factors. Your normal value is 4 to 8 minutes. K here is kinetics, also depends on fibrinogen, and it's about how much time it takes to have an appropriate level of clot strength. This is normally 1 to 4 minutes. The alpha angle here is the slope of the line between R and K, and it represents the speed at which fibrin cross-linking takes place. And so it's how fast the clot forms. So it relates to a burst of thrombin, also dependent on fibrinogen. So TMA, time to maximum amplitude, this is maximum amplitude, and that represents the ultimate strength and stability of the fibrin clot, which is about 80% dependent on platelets and about 20% on fibrinogen. And then this is your clot lysis time in seconds. And the reason this is helpful is it's a visual representation of what she has and what she lacks. Okay, so here, okay, this is a normal TEG. This is a patient who needs FFP. This is a patient who made a clot and it lysed too quickly. So that's where fibrinolysis is the problem. You need TXA. This is a patient who needs platelets, and so on, right? Again, I don't know if you have this. We do not have it in my labor and delivery unit. There are financial reasons for that. It's not a terribly expensive test, but the way it works in my country is somebody wants to get paid for it. Sample algorithms, in the interest of time, I will not. And I just want to show you this picture here. At my hospital 2 weeks ago, we had a run of peripartum hysterectomies. This one here is a placenta procreta who was diagnosed at 22 weeks. We diagnosed her at 22 weeks. At that point, she already would have needed a hysterectomy. And that would, of course, been a termination of pregnancy. She agonized over that for a while. But the placenta continued to invade. So we did a planned cesarean hysterectomy at 34 weeks here. You see this placenta here? You see these vessels here? It had invaded the bladder. There wasn't much of the bladder left. We thought it had invaded the sigmoid as well. So this particular patient, we had the luxury of planning. So we had her iliacs cannulated ahead of time. We had urology scrubbed in. She had a partial bladder resection. She lost 6 liters of blood, which is probably an underestimate. She got 9 units of packed cells. She got 8 units of plasma. She got 2 units of platelets and a little cryoprecipitate. The other procreta that we had also did pretty well. But the one who didn't do well was the one we weren't prepared for. That was the uterine case, who had a vaginal delivery of twins. And had uterine, but she spent 7 hours in the OR while they were farting around with what to do. And I think that probably atony wasn't her only problem. By the time she spent 7 hours in the OR, she was cold and acidotic, and she had a much worse outcome. And I hope I'm in under time, but I am done. Thank you.
Thank you very much, Professor Lauren. It's very interesting presentations, and you make it very much on time. So top of the list.
Thank you.
Okay. Well, actually, I really, we already have questions here, but I really want to continue forward to Sarah first, and then we will have another presentations by Dr. Burhan, and then we can get into this discussion. So without further ado, can you please replace this with Sarah Abu Tabih presentations to the IT team? Okay. Sarah as well is very interesting person in person, actually. Well, she's not just only an OBGYN hospitalist, but also she's a critical care intensivist as well. Now she's doing a cardiothoracic intensive care as well, and also sometimes DJ. Well, this is a very mixed combination, and I'm so thrilled to see you because I could see that why you could balance between those worlds. And now, without further ado, let's begin your presentations to see that you could always have the DJ spinning on around on your life. Okay, Sarah, please get it on. Thank you.
All right. Well, thank you so much for that kind introduction. And thank you so much for allowing me to be here today. It's such an incredible honor, and Bali is just such a beautiful country, although it's a little bit hot, but it's absolutely beautiful. So again, my name is Sarah Butabik. I am very excited to talk to you all about hypertensive emergencies in and out of pregnancy. Next slide. I have no conflicts of interest to disclose. Next. So first I wanted to start with two case scenarios, and hopefully by the end of this talk, we'll be able to answer them confidently. So first case is a 29-year-old G1P0. She's at 38 weeks and 1 day, BMI is 23. She's presenting with painful contractions every 6 minutes. She denies any past medical history. She denies any symptoms outside of painful contractions. Her labs are normal. Her blood pressure on arrival is 174/95 twice after being rechecked 15 minutes apart. The nurse is calling you and thinks her blood pressure is pain related. So what do you do? When do you recheck her blood pressure? What's her blood pressure goal? Is it not to treat this blood pressure? And let's compare that to another 29-year-old patient who's G0, BMI of also 23. She has a past medical history of chronic hypertension, and she's admitted to the surgical ICU after a motor vehicle accident for Q1-hour neurovascular checks after a lower extremity that was injured. She has no lab abnormalities and no symptoms outside of lower extremity pain that she reports is currently controlled on meds. The nurse is calling you to place a PRN order after her blood pressure also returns the same, 174/95 twice, after being rechecked 15 minutes apart. So what do you do when you recheck the blood pressure? What's her blood pressure goal, and how dangerous is it not to treat this blood pressure? So hopefully by the end of the lecture, we'll be able to answer these questions. Next slide. So our learning objectives are to review the definition of hypertensive urgency and emergency in the non-pregnant patient and understand when blood pressures require IV treatment. Next is to classify the different hypertensive disorders of pregnancy. Third would be to learn what is considered a hypertensive emergency in pregnancy and the importance of immediate treatment. And last is to recognize the significant differences in blood pressure management in hypertensive emergency between the obstetric and non-obstetric patient. Next slide. So first I'll start with the hypertensive emergency and urgency in the non-pregnant patient. Next slide, please. So hypertensive emergency, next please, is the definition of hypertensive emergency is severe elevations in blood pressure plus the presence of acute end organ damage. And so it's severe elevation of blood pressures plus evidence of acute end organ damage. And so this requires immediate control of blood pressures, ideally within 2 hours, to prevent further ongoing acute end organ damage. Next. And treatment requires IV meds with, usually we want the patient to be admitted to the ICU. We want invasive monitoring, usually an arterial line. And the main organs that we want to look at for evidence of acute end organ damage is mainly the brain, heart, and kidneys. Next. So this is just a graphic of the main organs that are affected. So again, brain, heart, and kidneys. So basically, if the patient is coming in with altered mental status, or if she's having focal neurologic deficits, or if she has a troponin leak, or if she has an AKI that's acute and different than her baseline, these all meet criteria for hypertensive emergency. Next. So what is the blood pressure cutoff for hypertensive emergency? So per the Society of Critical Care Medicine and per the American College of Emergency Physicians, there's actually no unified blood pressure cutoff that defines hypertensive emergency. And I was actually surprised to first learn this when I was a fellow in critical care, because I remember vaguely remembering some magic numbers of 180 or 220 or 120. And those numbers actually come from the American Heart Association, where they do have numbers that they define it as hypertensive emergency. But actually, there's no unified blood pressure cutoff that defines defines hypertensive emergency. And the reason for that is that we cannot accurately predict what magic number that the patient is going to develop acute end organ damage, right? So we've all seen patients out there who have blood pressures in the 220s range, right? And they don't have any evidence of acute end organ damage. And we've all seen patients with lower blood pressures like 160s, 170s that have evidence of acute end organ damage. And so basically, again, there's no unified blood pressure cutoff. So essentially, if she has, or if they have elevation of blood pressure and evidence of acute end organ damage, that's the definition of hypertensive emergency. And so the thing to know is that there's two main goals when it comes to treatment of hypertensive emergencies. The first is we want to lower the blood pressure to a level that prevents ongoing acute end organ damage. So again, it's the elevation of the blood pressure that's causing that acute end organ damage. So we want to lower that so we're preventing it from continuing. But then the second goal is you want to avoid dropping it too quickly because it's very easy to cause an iatrogenic end organ damage due to too precipitous of a drop in the blood pressure, because that ends up causing hyperperfusion to the organs. So it's this fine balance where, we want to lower the blood pressure so that it doesn't, continue to cause the acute end organ damage, but we don't want to drop it too quickly because then it causes relative ischemia for these patients. And so the goal usually is to lower the MAP by about anywhere from 15 to 25%, so about 20% within the first 2 hours for any hypertensive emergency, with one exception. Essentially, if the patient is coming in with aortic dissection, that's a patient where no matter where they live at baseline, we want to lower their blood pressures. At least in the States, we want it less than 120 systolic, and we want their heart rate typically less than 80. And the reason for that is just the sheer pressure of blood pressure is going to further worsen that dissection, right? So even if this patient is normally lives in the 200s, again, it's one of those things where we have to choose what's the lesser of two evils, and so we don't want to make the aorta explode. So that's why that's the one exception where universally we want the blood pressure less than 120. But otherwise, again, we want to lower the blood pressure by about 20% over the first 2 hours. And again, the reason for this is that too rapid of a reduction in blood pressure to achieve a normal level can be below that patient's autoregulatory capacity in someone who's a chronic hypertensive, which then can cause relative hyperperfusion in that patient, which then can further worsen their end organ damage. Next. So I just want to take a moment to review autoregulatory capacity. So, normally our important organs like our brain, heart, and kidneys have the ability to adjust the blood vessel size based off of what the pressures are. So we could see over here, this has cerebral blood flow on this axis. We have MAPS on this axis. And so normally there's a range where, the blood vessel can constrict or dilate. And so normally if our blood pressures are very high, our blood vessels will constrict so that it's not too high of a pressure so that it doesn't just blast that blood vessel, and so that the blood vessel doesn't get damaged, and so that the end organ doesn't get damaged. However, there is a maximal constriction that occurs. So essentially, there is an upper limit of how much the blood vessel can constrict, and such that after that point, then it can no longer constrict any further. And you can see that, this is the range right over here where normally, again, there is autoregulatory capacity, but then above a certain blood pressure, you no longer can constrict any further. And so this will cause increase in the blood flow to the brain, which again puts that brain at risk for hemorrhagic stroke. And then there's also a point of maximal dilation as well, where there's a lower end where, again, the blood vessel can't dilate any further. And so any blood pressure is lower than that, then it will cause relative hypoperfusion to the organ. Next. And so it's important to see how this graph shifts for someone who's a chronic hypertensive. So we can see over here the dotted line is what the graph looks like in someone who is a chronic hypertensive, compared to the solid line is what the graph is in a normal tensive patient. So we can see here that the graph shifts rightward in a patient who is a chronic hypertensive. And so if you could push next. You could see that essentially this patient's ability to auto-regulate is shifted rightward. So essentially what that ends up meaning is that there is a higher chance of the patient having relative hypoperfusion at much higher blood pressures. And so that's why they end up getting relative hypoperfusion and ischemia if we lower the blood pressure too precipitously. So that's why it's very, very important that, it's a very tight regulation that management for these patients. So again, we want ideally to lower the blood pressure by about 20% within the first 2 hours. Next. Okay, so that's everything for hypertensive emergency. So again, it's severe elevations in blood pressure with evidence of acute end organ damage, and the emphasis is on acute, not chronic end organ damage. Next, we'll talk about hypertensive urgency. So definition of hypertensive urgency is severe elevations in blood pressure, but there's no evidence of acute end organ damage. So these are patients, who have, severe elevations in blood pressures, like, 180s, 200s. Again, there isn't a universal number that defines hypertensive urgency. And these are patients who do not have any evidence of acute end organ damage. And so for these patients, if they don't have any evidence of acute end organ damage, our goal is to reduce the blood pressure over the next 24, 48 hours. And so this is a case where it doesn't require treatment with IV medications. In fact, you don't want to really treat it with IV meds because then it'll drop them too quickly. And ideally, you want to just control it with oral medications. This doesn't require admission to the ICU. In fact, oftentimes a lot of people don't even admit these patients. This is a situation where once you confirm that there's no evidence of acute end organ damage, some people will just, have the patient double their amlodipine and, have them check if they're compliant, have them, recheck their blood pressures twice daily and, come back in if it's not lowering. So, so yeah, again, basically with these hypertensive urgency patients, this is more associated with chronic end organ damage. So, these are patients who are at risk for, angina, CKD. These are patients who often have prior strokes, but again, they don't have any evidence of acute end organ damage. So it's not urgent to treat these patients. Again, immediately, our goal is to lower it by about 20% over the next couple of days. And, but again, they're patients that you don't want them to be living in this range, over days and weeks, because then it could cause chronic end organ damage. So I just want to review basic goals as far as the definition of chronic hypertension in the non-pregnant patients. And so normal blood pressure is, in the 110s, and you want the diastolic to be less than 80s. I remember a time when 120 over 80 was the goal, but actually that's considered, anything in the 120s is considered pre-hypertension or elevated blood pressures. And anything in the 80s is actually considered stage 1 hypertension. So stage 1 hypertension is anything in the 130s systolic over anything in the 80s diastolic. And stage 2 hypertension is anything in the greater than 140s or anything greater than 90s diastolic. All right, so that's it for hypertensive emergency in the non-pregnant patient. So essentially, hypertensive crisis is either hypertensive emergency or hypertensive urgency. Hypertensive emergency is severe elevation in blood pressures with the evidence of acute end organ damage. Hypertensive urgency is severe elevations in blood pressures with no evidence of acute end organ damage. Essentially, the presence of acute end organ damage is what separates the definitions of these two. And know that, again, there's no specific blood pressure cutoffs that define hypertensive crises. So again, if you see evidence of acute end organ damage, you want to lower their blood pressures by about 20% in the first 2 hours, admit them to the ICU, place an A-line, and it should be treated with IV meds. Otherwise, if there's no evidence of acute end organ damage, that's considered hypertensive urgency. You do not want to treat with IV medications. That's not indicated. It can be treated with oral meds, and the goal is to reduce blood pressures within the next 1 to 2 days. So to review the case on the right, so 29-year-old G0, BMI is 23. She has a past medical history of chronic hypertension. She's admitted to the surgical ICU after a motor vehicle accident for Q1-hour neurovascular checks of her lower extremity that was injured. She has no lab abnormalities and no symptoms outside of lower extremity pain that she reports is currently controlled on meds. The nurse is calling and asks to place a PRN order after her blood pressure returns 174 over 95 after being rechecked 15 minutes apart. So what do you do? So for this patient, she technically meets criteria for hypertensive urgency. So she doesn't have any evidence of acute end organ damage. And so for a patient like this, I would say it depends on whether she's already on an antihypertensive or not. If she is on an antihypertensive, I would probably go increase her dose. If she's not on an antihypertensive, I'll probably start her on something like amlodipine. When do you recheck her blood pressures? So you want to recheck it. Again, this is something that our goal is to manage it. It's within the lower it within the next couple of days. She's already in the ICU, so it'll be checked within an hour, but it could be checked within the next few hours. What is her blood pressure goal? So her goal is to reduce it by about 20% over the next 24 to 48 hours. So I would say her goal is anywhere from 130s to 140 systolic over the next couple of days. And how dangerous is it not to treat the blood pressure? Not extremely dangerous. Again, I mean, I don't want her living in this range for a long period of time because, she's young. It will put her at risk for chronic end organ damage. But it's not extremely important to treat it precipitously right now with IV meds. So not super dangerous not to treat it. Okay, next. I always say there's not many things, benefits that we got from the pandemic, but the one thing it did provide me as an OBGYN at least is job security. Next. Okay, so next we'll go over hypertensive emergency in the pregnant patient. So everything I'm discussing is per the American College of OBGYN practice bulletins and their management recommendations. So why do we care? Why is it a big deal to have hypertension in pregnancy? So first off, the CDC reports that 1/3 of adults greater than age 20 have hypertension. I myself am a chronic hypertensive. Again, 1 in 3 people have hypertension. And, believe it or not, I truly believe this is an underestimate, right? These are people who we know have a known diagnosis. I think it's way higher than that, actually. Up to 10% of pregnancies in the US is complicated by hypertension. 3 to 8% of pregnancies in the US are affected by preeclampsia, and preeclampsia is a big deal. Why is it a big deal? For a few reasons. One is that it's the cause of 15% of all preterm births. It's also the cause of 26% of maternal deaths worldwide and 30% in the US. Again, that's a huge deal. These are otherwise young patients who should not be dying. The rate of preeclampsia is increasing significantly, and the cost of preeclampsia is very expensive, $2.2 billion in the first 12 months. Again, we know that preeclampsia is one of the top 3 causes of maternal mortality, so that's why it's a big deal. And so the thing to know is that hypertension, the hypertensive disorders in pregnancy is on a spectrum. Essentially, when it comes to anything related to pregnancy, we don't blame it on the pregnancy until the patient is about 20 weeks. So if the patient is diagnosed with high blood pressures before 20 weeks, or if she's diagnosed with, has an elevated A1C before 20 weeks, then we call that either chronic hypertensive or type 2 diabetes. Anything after 20 weeks, assuming that she doesn't otherwise have a known history of chronic hypertension, then we call it at least gestational hypertension. And so gestational hypertension can progress to preeclampsia without severe features, which then can progress to preeclampsia with severe features, and then which can progress to eclampsia. So when it comes to diagnosing hypertensive disorders of pregnancy, the way we diagnose it is hypertension is defined by either having 2 blood pressures separated by at least 4 hours with either the systolic greater than 140 or the diastolic greater than 90. So let's say I'm 12 weeks pregnant and I go to my doctor's office and my first blood pressure that's checked is 125/93. And then let's say I go to my doctor 4 weeks later and my blood pressure is 117/92. That technically meets criteria for chronic hypertension. Okay. So it's basically 2 blood pressures separated by 4 hours. And essentially, whether it's called chronic hypertension or gestational hypertension is dependent on how many weeks pregnant she is. So again, if she's less than 20 weeks in gestational age, or if she's greater than 12 weeks postpartum, that's considered a chronic hypertension. If she's greater than 20 weeks gestational age and has hypertension in the absence of a prior known history of any hypertension, then it's at either gestational hypertension or preeclampsia. Severe range hypertension is defined by having 2 blood pressures with either the systolic greater than 160 or a diastolic greater than 110. And so the thing to know is that any systolic greater than 160 or diastolic greater than 110 that occurs twice is considered the hypertensive emergency of the pregnant patient. And this is a situation that requires immediate treatment. We want to treat it as soon as possible. Unlike the non-pregnant patient where, we have up to 2 hours to treat it, this is a situation we want to treat it as soon as possible, ideally within 15 to 30 minutes, but absolutely not to exceed anything more than 1 hour. Next. And so this is straight from the American College of OBGYN, the definitions of hypertensive disorders. Okay, go next. And so essentially, so again, basically gestational hypertension is if the patient is greater than 20 weeks pregnant and she has that meets the diagnosis for hypertension and she does not have any evidence of protein in her urine. The difference between gestational hypertension and preeclampsia without severe features is essentially if there's protein in her urine. So it's essentially the patient has hypertension, she's greater than 20 weeks, and she has evidence of proteinuria. We have 3 different ways of diagnosing proteinuria in a preeclamptic patient. One is we could do a 24-hour urine protein collection, and if that number is greater than 300 milligrams, that meets criteria. Or you could do a urine protein to creatinine ratio. If that's greater than 0.3, that meets criteria for proteinuria. Or if she has a urine dipstick protein of greater than 2+ or more, that meets criteria. When it comes to the urine dipstick, we ideally try not to use that with the exception of low resource settings, just because it has a very high false positive rate of 71%. I would say most commonly we use the urine protein to creatinine ratio just because it's less burdensome than collecting urine for 24 hours. So the only difference between gestational hypertension and preeclampsia without severe features is the presence of protein in her urine. And what the definition of preeclampsia with severe features is we could define it by one of three major categories. So essentially, preeclampsia with severe features is the hypertensive emergency of the pregnant patient. And we define it one of three ways. One is blood pressure criteria. So if she has two blood pressures of greater than either 160 systolic or 110 diastolic, that meets criteria. Second is symptom criteria. So if there's symptoms of acute end organ damage. So one is if the patient has hypertension and she has refractory headache that is unresponsive to medications like Tylenol or some headache cocktail, then that meets criteria for preeclampsia with severe features. Next is if she has visual changes. So when it comes to these visual changes, typically they're scotomata or flashing lights. I would say just be mindful. Oftentimes it's very common for pregnant patients to comment on having more increased blurred vision, but blurred vision is something that can be a physiologic change of pregnancy. There's swelling that occurs in the cornea, so it's just important to distinguish with the patient how acutely the swelling occur. If it happened, overnight within hours, that is very concerning. Versus if she says like, oh, ever since I was pregnant, I just noticed I had to change, my glasses, or it's harder for me to read magazines, then that's not as concerning. And then next is if she has persistent epigastric or right upper quadrant pain, that can be a symptom of end organ damage. And specifically what we are worried about is that there is hepatic cell edema, or a focal parenchymal necrosis, which then causes stretching of the liver capsule. The name of the liver capsule is called Glitzen's capsule. And so this causes severe right upper quadrant pain. So I would say it's really important to clarify with the patient, this isn't just like, oh, it kind of bothers me here, baby's kicking me in that area. No, this is severe refractory, 10 out of 10 pain. So it's something to clarify with the patient. And then lastly, if she has acute onset pulmonary edema that is not otherwise explained by any other causes, that is considered a severe feature of preeclampsia. And then lastly, another way to diagnose preeclampsia with severe features is laboratory evidence of end organ damage. So this is one of the things that can cause this is something called HELLP syndrome. But essentially, if her platelets are less than 100,000, that meets criteria. Or if her creatinine is greater than 1.1 or double her baseline creatinine, that meets criteria. So one of the physiologic changes of pregnancy is that there's a significant increase in plasma volume. So a normal creatinine in pregnancy is typically less than 0.5. So if I have a patient who has a creatinine of like 0.8, 0.9, that's actually pretty abnormal. Again, it doesn't quite meet criteria for preeclampsia, but unless we have a baseline creatinine in that patient. But it is a situation where I would be concerned that she may be brewing a severe pre-E. Or another criteria is if her liver enzymes are twice the upper limit of normal, that meets criteria for laboratory evidence of end organ damage. Or if there's evidence of hemolysis. So if her hemoglobin is downtrending, her LDH is elevated, she has elevated uric acid, that meets criteria. So essentially, again, when it comes to preeclampsia with severe features, again, this is the hypertensive emergency of the pregnant patient. There's three main ways to diagnose it. So again, blood pressure criteria, symptom criteria, and lab criteria. And then lastly, at the end of the spectrum, can you go back for a second? There is eclampsia, which is essentially if you have a pre-E in the setting of having a tonic-clonic seizure in the absence of a history of epilepsy. So that's the worst case scenario. You can go next. And again, this is all straight from the American College of OBGYN practice bulletins as far as how we define the diagnostic criteria for preeclampsia. Just know when it comes to severe hypertension, again, this can be confirmed within a short interval, basically because it's very important to facilitate timely antihypertensive delivery. Next. And again, hypertension in pregnancy is on a spectrum. Essentially, again, we don't blame it on the pregnancy until she's at least 20 weeks gestational age, assuming she doesn't otherwise have a history of hypertension. And we could blame it on the pregnancy all the way up until 6 weeks postpartum. Yeah, I always love these memes that came out during COVID. So it says, stay at home unless you want an OB/GYN managing your ventilator instead of your labor. A lot of the patients ended up with this clinical scenario. Okay, next is eclampsia. So eclampsia is when you have a tonic-clonic seizure in the setting of preeclampsia. There's a wide incidence, so it's anywhere from 1 in 100 to 1 in 4,000. So why is this a big deal? Well, it's a big deal because it's a huge cause of maternal mortality. So it's 25% maternal mortality in resource-limited countries. It's a little bit less, up to 7% in developed countries. And the reason for that is that having a seizure is a very resource-intensive disorder to have. So it requires, nurses to recognize it, people to run in, turn the patient, help preventing aspiration and so forth. And so eclampsia can present essentially anytime during pregnancy. So, in the antepartum period, intrapartum, or postpartum period. The thing to know that if it is going to happen postpartum, 26% occurs within 48 hours after birth. And the thing to know is that the most common symptoms that precede an eclamptic seizure is a persistent headache, plus or changes in vision. And so it occurs before 83% of eclamptic seizures. So that's just one of the many reasons why we take these symptoms very, very seriously. Next slide. So why is eclampsia a big deal? Okay, so mom seizes, people seize all the time. Why is this a big deal? Well, seizure is a big deal when you're pregnant because when you seize, the mom's not breathing. If mom's not breathing, then it leads to hypoxia and baby's not getting sufficient oxygen. It also leads to trauma. So mom can hit her head, she can hit her belly. Also, mom can have aspiration pneumonia. And after, working in the ICU, we know aspiration pneumonia is a big deal. Also, eclampsia, believe it or not, you can see permanent white matter loss on a fourth of MRIs in these patients. And again, we mentioned before that up to 83% of patients or an eclamptic seizure is preceded by signs of cerebral irritation. So that's why it's really important to take these signs seriously. And, believe it or not, up to 38% don't even have any signs of preeclampsia. So it just goes to show we still have a lot of learning to do when it comes to preeclampsia. So let's say, we're in the hospital and one of the nurses is calling that, hey, patient in room 1, she's seizing and she's 28 weeks. What do we do? So first thing you want to do is you want to call for help. So ABCs come first. So call for help. You want to place the patient in the left lateral decubitus position to help prevent aspiration. You want to place oxygen on her. You want to check her vitals. So believe it or not, MAG is not the first thing. Again, ABCs always come first. I personally also recommend taking the fetus off the monitor. Again, treatment of eclamptic seizures, you want to treat mom before that's the way you treat baby. So I find that, having the baby on the monitor, we know the baby's not going to look good. The heart rate's going to be looking down. And I just find that it distracts often from the treatment of mom. So I actually recommend taking the fetus off the monitor. And then once we take care of our ABCs, then our first line treatment for eclamptic seizure in a pregnant patient is magnesium sulfate. You want to give anywhere from a 4 to 6 gram IV bolus of magnesium sulfate if she has an IV. If she does not have an IV, you want to give her 10 grams of intramuscular magnesium sulfate, 5 in each buttock. And this is used to prevent recurrent seizures. So eclamptic seizures tend to be short-lived but recurrent. So magnesium sulfate, it doesn't abort an active seizure going on, but it helps prevent recurrent seizures. And so this has been shown to be superior to all the other antiepileptics, phenytoin, diazepam, lorazepam. And so essentially, you want to give anywhere from 4 to 6 grams. I recommend if the patient has not received magnesium already, that you should start with a 6-gram bolus. If she already has a magnesium drip going on, or if she's already received IM mag, then I would start with a 4-gram bolus. So let's say, okay, we give 6 grams of IV magnesium sulfate and the patient is still seizing. What do we do? Then you want to give her another bolus of magnesium sulfate, anywhere from 2 to 4 grams IV magnesium sulfate. And let's say she's still seizing despite this, then at this point, then, we should, hopefully we had called the ICU colleagues, anesthesia colleagues ready to be in the room, but at this point we should be considering intubating the patient for airway protection. And then you want to treat her with benzodiazepine. So we know that lorazepam is a first line for seizure treatments outside of magnesium sulfate. And so you want to intubate, you can start her on a propofol or a pentobar drip, and then, consider imaging once she's stable. So let's say with this patient, we went in, the patient was seizing, we put her on her left lateral decubitus, took the baby off the monitor, put oxygen on her, gave her a 6-gram bolus. She was still seizing despite the first bolus, so we gave her another 2-gram bolus. And now she's no longer seizing, and she is, a little post-ictal, she's drowsy, but however, she's following commands, moving all extremities. What should we do at this point? Let's say she's 28 weeks pregnant. So once Eclampsia is an indication for delivery regardless of gestational age, okay? So eclampsia is an indication for delivery. It's not necessarily an indication for C-section, but it depends on, within reason, how soon can we accomplish delivery. So let's say this patient was actually, in labor already, she was 6-7 centimeters, then definitely we could continue on the vaginal delivery route. However, let's say this is the 28-weeker that I mentioned earlier. This is a patient that it could take days, to deliver this patient. And so I would go to C-section because it's higher risks of keeping her pregnant. So what causes preeclampsia? So preeclampsia is thought to be a disorder of the placenta. And so it's thought that the placenta essentially secretes cytokines that causes blood vessels to spasm. And so the spasming of the blood vessels systemically is what causes blood pressures to go up. Spasming in the brain, it causes abnormal cerebral perfusion pressures. That's what causes a severe headache. Spasming in the ophthalmic arteries is what causes scotomata. Spasming in the liver is what causes hepatic cell edema and necrosis. And spasming in the kidneys is what can cause the AKI. And so ultimately, the ultimate treatment of preeclampsia, since we think it's a disorder of the placenta, is get rid of that placenta, right? So that means ultimately delivery. And so for us, patients with severe preeclampsia, we deliver at 34 weeks gestational age. For preeclampsia without severe features, or for gestational hypertension, we deliver at 37 weeks. There's, of course, exceptions to this rule. So someone who's having an eclamptic seizure, for example, we're delivering them right at whatever gestational age she is. And so, it's been shown that the only thing that has been really been shown to be helpful to help reduce the risk of preeclampsia is by taking aspirin. And so it's recommended for patients who had a higher risk for preeclampsia to take baby aspirin. US studies looked at 81 milligrams. European studies took 2 baby aspirin, so 160 milligrams. But the important thing is you want to start at 12 weeks. And the way I think of it is, again, the placenta is just a big ball of blood vessels. And so by taking aspirin, it helps create more normal endothelial function, and hopefully it doesn't secrete those abnormal cytokines as much. Okay, so again, preeclampsia with severe features is the hypertensive emergency of the pregnant patient. So there's 2 main goals when it comes to the hypertensive emergency of the pregnant patient. So one is prevention of the eclamptic seizure. And so there was something called the MAGPIE trial, which was a randomized placebo-controlled trial with greater than 10,000 participants, both in developed and undeveloped countries. And it showed the eclamptic seizure rate was reduced by 58% by giving magnesium sulfate. And so in terms of how much mag should we give, essentially anyone diagnosed with preeclampsia with severe features in the United States, we treat her with magnesium sulfate. We usually give her about anywhere from a 4 to 6 gram bolus of magnesium sulfate over about 15-20 minutes, followed by 2 grams, 1 to 2 grams an hour. Or you could give magnesium sulfate intramuscularly. The loading dose is 10 grams intramuscularly, so 5 grams in each buttock, followed by 5 grams intramuscularly Q4 hours. And that, again, that has been shown to reduce the eclamptic seizure rate by 58%. A lot of European countries give magnesium sulfate to both preeclampsia without severe features and with severe features. Again, in the States, we just give it for severe features. The thing to know is that whenever we give magnesium sulfate, it's important to monitor the patient closely, because we know that magnesium is almost exclusively cleared by the kidneys. And we know that patients with preeclampsia with severe features are at risk for developing AKI. And so essentially, patients who are on magnesium sulfate, the way we monitor them is not by using actually serial magnesium levels. We monitor them by monitoring their urine output. And then we also check their deep tendon reflexes. So magnesium is a divalent cation, just like calcium is. And so it competitively, it will compete against calcium at the level of the sarcoplasmic reticulum at different muscles. And so the very first sign of magnesium toxicity is loss of deep tendon reflexes. I don't know how your anesthesia boards work over here, but I know that's a very common question that they like to test in the States as far as, what's the first sign of magnesium toxicity? So the answer is loss of deep tendon reflexes. And so our nurses are the ones typically doing magnesium checks, so assessing the patient's deep tendon reflexes, and if they are suppressed or decreased, then at that point we would get a magnesium level. So the very first sign of magnesium toxicity is loss of deep tendon reflexes. So if the patient has that, you want to stop the magnesium infusion, and then you want to get the magnesium level, and then you want to consider giving her the rescue for magnesium toxicity is calcium gluconate. if the patient has severe elevations in magnesium levels, then it could displace the calcium at the level of the diaphragm, and that's how it causes respiratory paralysis. So that's the next sign of toxicity. To be honest, it takes a lot of magnesium to reach that point, but again, it's just very important to keep a close eye on the patient's urine output and her deep tendon reflexes to make sure it doesn't reach that point. And then worst case scenario, magnesium toxicity can cause cardiac arrest. How much mag to give and what the therapeutic range is, it depends on what your units are. So there's 3 different units when it comes to magnesium sulfate. And so these are all, this chart demonstrates what the therapeutic ranges are. Although I should mention that, to be honest, what the therapeutic ranges, again, we don't routinely get magnesium levels in patients. And so honestly, what the magic number is and therapeutic range is, it's really, I would say, not really consistent data to show what it is, because again, the honest truth is we often don't check it very often. So we just know that having mag in the system is definitely helpful for reduction of the eclamptic seizure. Okay, so we mentioned 2 main goals when it comes to pre with severe features. So first is prevention of the eclamptic seizure. That's easy, just throw magnesium sulfate at that, right? Second goal is you want to control the hypertension, and ideally you want the blood pressures to be less than systolic of 160 or diastolic of 110 to prevent acute end organ damage. And so essentially, again, there is a magic number when it comes to pregnant patients. And again, universally, all pregnant patients, doesn't matter if she has a chronic hypertension, lives in the 200s, pre-pregnancy, universally we want every single one of these patients to have a systolic less than 160 or diastolic less than 110. And the reason for that is we know that pregnant patients, when it reaches numbers greater than 160 over 110, that they have a much lower threshold to have acute end organ damage occur. And particularly when hemorrhagic stroke, they have a significantly increased risk of hemorrhagic stroke once the numbers are greater than 160 systolic or 110 diastolic. So again, the goal is to lower the blood pressure to prevent acute end organ damage. And so it's been shown blood pressure is greater than 160s over 110s is associated with hemorrhagic stroke. It could be CHF exacerbation, myocardial ischemia, AKI. I always say the fetus is an excellent marker of end organ perfusion. So there could be fetal growth restriction, placental abruption, fetal death, and NICU admission. So again, if the patient has blood pressure is greater than 160 systolic or greater than 110 diastolic, we need to treat this very precipitously as soon as possible. Think of it as every second that she's in the range, it's just blasting her blood vessels at risk for hemorrhagic stroke. So basically the goal is you want to treat it as soon as possible. So why is it that, this is very unique? How come in pregnant patients we could say universally it doesn't matter, even if she's a chronic hypertensive and lived in the 200s pre-pregnancy, why is there this universal goal of 160, greater than 160, we want everyone less than 160 systolic or less than 110 diastolic? And the reason for that is that pregnant patients with preeclampsia have much higher risk, again, of hemorrhagic stroke. And the reason for that is that they don't have the ability to auto-regulate. So they have significant impairment of autoregulation in pregnant patients, specifically, especially when it comes to cerebral autoregulation. And so this is why, again, whereas normally in a non-pregnant patient, most of us can, autoregulate at that range, pregnant patients do not have that ability to autoregulate when the blood pressure is greater than 160 and over 110. And so that's why universally, it doesn't matter where she lived before, if she's pregnant, these are just blasting those blood vessels. She cannot autoregulate. She can't protect her organs. So it's very important to treat it as soon as possible. So again, we want to treat it as soon as possible, ideally within 60 minutes, but this doesn't mean wait until minute 59 to treat it. Again, every second she's exposed to this, just think of it as stroke range blood pressures. And so blood pressures that remain higher than the 180s after despite initiating meds, these patients have significant morbidity and mortality. And so it's very important to really keep a close eye on her blood pressures. Let's say I give her IV medications, I bring the blood pressure down. Even if the recheck blood pressure is lower than 160 over 110, we watch it very, very closely. Next. So again, I just want to touch on this autoregulatory capacity. So again, you can go to the next slide. So again, in pregnant patients, they do not have the ability to autoregulate past the systolic of 160 or past the diastolic of 110. So again, universally, all these patients, again, just think of it, it's just blasting those blood vessels. And so it's really important to treat it as soon as possible. Next slide. So pregnant patients do not have this. Okay, so how do we treat patients who have elevated blood pressures? So we have essentially there's 3 main medications that we use. So the main medications that we can use is either IV labetalol, IV hydralazine, or instant release nifedipine. All three of these are first-line medications for hypertensive emergency or severe preeclamptics. So when it comes to labetalol, essentially we usually start with either 20 milligrams, and if that doesn't work, then we give her 40 milligrams. If that doesn't work, then we give her 80 milligrams. If that doesn't work, then we give her 80 milligrams again. Although I would say if it still doesn't work after the 80 milligrams, I usually switch to hydralazine at that point. Or we could use IV hydralazine. So we first can start with 5 milligrams. If that doesn't work, then give her 10 milligrams. If that doesn't work, then give her 10 milligrams again. Or we could use instant release nifedipine, either at 10 to 20 milligrams orally, and you could repeat it every 20 minutes. A very common question that a lot of people ask me is, which one do you use first? And I'll say the heart rate really helps me dictate which one I will go to first. And two main things, what the patient's heart rate is and whether she has IV access. So if she doesn't have IV access, I will give her instant release nifedipine. I know intuitively, we tend to, feel like IV medications work better than oral medications. But believe it or not, just anecdotally with my experience, nifedipine actually works quite well. And I would say, I always try to encourage my residents, like, don't delay treatment just, while trying to get an IV in, like, give her the instant release nifedipine. In my experience, it typically drops the systolic blood pressures anywhere from 20 to 40 points. So I would really encourage considering this. It works very well. I use it in my cardiothoracic ICU all the time as well. So yeah, if she doesn't have an IV, I give her instant release nifedipine. If she does have an IV, basically I base it off her heart rate. If she's tachycardic, then I'll give her labetalol because we know it has this side effect of reflex bradycardia. If she's bradycardic, then I'll give her hydralazine because we know it has a side effect of tachycardia. So let's say we have a patient coming into our labor and delivery triage, and let's say her blood pressure is 180 over 92. What do I do? So let's say I give her instant release nifedipine. I'll give her 10 milligrams instant release nifedipine. How soon do we recheck the blood pressure? So first, you want to recheck the blood pressure after 10 minutes after giving IV labetalol. You want to recheck the blood pressure after 20 minutes with giving her anything else, either IV hydral or nifed. So let's say I give her the 10 milligrams of instant release nifedipine, and let's say now after 20 minutes, I recheck her blood pressure, and her blood pressure is 140 over 80. What do I do next? Per the American College of OBGYN, it says after her blood pressure is successfully lowered, then it recommends repeating her blood pressure measurement every 10 minutes for 1 hour, followed by every 15 minutes for 1 hour, followed by every 30 minutes for 1 hour, followed by every hour for 4 hours. This is very intense. There's nobody in my ICU where I'm checking their blood pressures this often. And so it just goes to show how seriously we take this. This is a huge deal. We want to watch her very, very closely. And so again, it just requires very close monitoring of this patient. This is a sample order set per the American College of OBGYN. I'll skip this slide for now. And so to summarize, again, cerebral autoregulation is impaired in the pregnant patient with any hypertensive disorders. So they have a much higher increased risk of stroke and acute end organ damage at much lower blood pressures compared to the non-pregnant patient. And so, and there's significant morbidity and mortality, both for mom and the fetus with any hypertensive disorder of pregnancy. So it's very important to treat her very precipitously, as well as, treating her with magnesium sulfate to help prevent the eclamptic seizure. So again, remember, there's two main goals when it comes to hypertensive or preeclampsia with severe features in a pregnant patient. One is prevention of the eclamptic seizure. The way we prevent that is with magnesium sulfate. The second is prevention of acute end organ damage, and that's by treating her blood pressures, and the goal is less than 160 systolic or less than 110 diastolic. And again, IV labetalol, IV hydral, or instant release nifedipine are all first-line medications that can be used. You want to treat these blood pressures as soon as possible. So unlike the non-pregnant patient, we can kind of sit around. This is a situation where you want to treat it very precipitously. This is something that, I remember as an OB resident prior to doing my critical care training. I think for OBGYNs out there, it can be an area of a little bit of frustration just trying to communicate with our ICU colleagues to treat these blood pressures more precipitously. And I can understand now, having, learned what the hypertensive emergency is of the non-pregnant patient, we have 2 hours to treat it, right? So, and our goal is not to drop it too quickly. But again, in this situation, we want to drop it, as soon as possible, again, below those magic numbers of 160 over 110. And it's very important to recheck the blood pressures frequently, even once her blood pressures have normalized. The last thing I want to mention is, a lot of times people ask me, what is more important? Let's say, we have a patient coming into the emergency room, her blood pressure, she's pregnant, her blood pressures are in the 180s. What's more important, to start the magnesium sulfate or to treat her blood pressures? So I would say definitely by far, treating the blood pressures is the most important. I mean, ideally, these are happening simultaneously, right? But the chances of her having an eclamptic seizure right at that moment is not as high as the chances of having acute end organ damage right in that moment. So again, just think of it, every second that she's exposed to severe elevations of blood pressure, that puts her at risk for acute end organ damage. So again, ideally, these are things happening simultaneously, but if you have to choose one over the other, definitely you want to treat her blood pressures first, and lower it so that it reduces her risk of acute end organ damage. So to go back to our case scenario, so for our first patient, a 29-year-old G1P0 at 38 weeks and 1 day, BMI is 23, she's presenting with painful contractions every 6 minutes. She denies any past medical history. She denies any symptoms outside of painful contractions. Labs are normal. Blood pressure on arrival is 174/95 twice after being rechecked 15 minutes apart. The nurse is calling you and thinks her blood pressure is pain-related. So what do you do? So this is the hypertensive emergency of the pregnant patient. This is a big deal. She has pre with severe features, so we need to treat this blood pressure as soon as possible. So I would say if she doesn't have an IV, give her instant release nifedipine. If she does have an IV in place, then I would, look at her heart rate. If she's bradycardic, give her hydrol. If she's tachycardic, give her IV labetalol. When do you recheck her blood pressure? So essentially you recheck it after 10 minutes for IV labetalol. You recheck it after 20 minutes for anything else, hydrol or nifed. What is her blood pressure goal? So her blood pressure goal is less than 160 systolic or less than 110 diastolic. And how dangerous is it not to treat this blood pressure? It is extremely dangerous. And so I think this is a really good example. You see it's, for these two clinical scenarios. Same age, same BMI, right? But the one being pregnant, one being not pregnant, how different we treat it and how dangerous this is for the patient. So it is extremely dangerous for us not to treat the blood pressure, and our goal is to lower it as soon as possible. And so with that, again, thank you so much for having me here, and I'll be happy to take any questions.
Thank you very much to Sarah, and thank you very much to Prof. Lauren also. Well, very compact and very interesting presentations. Both of you are excellent in this matter, but we have many questions yet, and we need to answer it, and we need to, I think we have several things to clarify. I already got some questions from our fellow OBGYN. This is one of the senior OBGYN from RSUP Prof. Ngurah, Dr. Jaya Kusuma. Hello. He would like to ask about the eclampsia when the MAP is less than 100, and I'm sorry, maybe the systolic less than 150. Would you consider it still an emergency hypertension or maybe something else?
That is an excellent question. So essentially, we define it as a hypertensive emergency universally. It's that magic number of greater than 160 systolic or greater than 110 diastolic. If it's less than that, then I'm not considering it a hypertensive emergency. However, at the same time, it is something that ideally I would like to lower, but this is a situation I wouldn't give IV medications. I would give oral medications. But I would say this is a situation where I probably will need more data points, right? So I would say a solitary blood pressure of 150s, I wouldn't necessarily treat if all of her other blood pressures are, 110s, 120s. But if she's persistently in the 140s or 150s, then that is something that we want to treat. There was a trial that came out a couple of years ago that was called the CHAP trials, chronic hypertension in pregnancy. And essentially what that showed was that our goal is to lower the blood pressure for chronic hypertensives to a goal of less than 140s systolic and less than 90s diastolic. So that would be a situation I would give oral medications and not IV.
Okay, perfect. Because you're also answering the second question, because he's asking about what is our perspective and what kind of the antihypertensive you recommend to reduce the blood pressure or maybe the systolic blood pressure or maybe the MAP. Maybe it's better for the oral treatment or maybe for the IV treatment.
Sure. So let me just start by saying that all our literature in obstetrics for preeclampsia is done with systolics and diastolics and not by MAPs, actually. So we don't use MAPs at all when it comes to management. It's all dictated by systolics and diastolics, which is a little bit different than my ICU. It kind of depends. Sorry, can you repeat the question? What the question was?
Actually, he's asking whether we want to choose between the oral or maybe IV. Maybe for the first line, or maybe something happened, or we cannot find access, or something else like that.
So So I would say if she's persistently in the severe range, so greater than 160 systolic or 110 diastolic, then I would use any one of those three medications, which are all first line. So either IV labetalol, IV hydralazine, or instant release nifedipine. If we can't get access, I would give instant release nifedipine. Honestly, it works very well. And I think, again, I think intuitively we feel like because we're not giving it through the IV, it's not as strong, it doesn't work as well. But in my anecdotal experience, it works really well. So I have a very low threshold. If she doesn't have an IV, give her instant release nifedipine. And yeah, I wouldn't delay things to get an IV. So I would treat her. I don't know if Dr. Plant, if you have anything that you want to chime in
Perfect.
on
Yeah.
with this.
Perfect. Okay. Nifedipine is already, as long as you don't delay the patient, then everything is okay between oral or IV. Okay.
Yeah, correct. Time is of the essence. Every second
Yeah.
she's above those numbers, it's just blasting those blood vessels. So you want to treat it as soon as possible.
Okay. For Prof. Lauren, what do you think about your opinion about the possibility of potentiation effect from the magnesium sulfate that Sarah already told us, if we use it in the same time with the anti-hypertension? Because sometimes we potentiate and we could only get it in a very low and bradycardic patient. So what do you think about it?
So potentiation of antihypertensives and magnesium.
Yes,
Yeah, so
correct.
when I'm old enough now to have seen this a couple of different ways. At one point we thought that magnesium alone was a decent antihypertensive, and it's true that you get a little bit of vasodilation in the first 20 or 30 minutes after magnesium, but it doesn't last. It's not a functional antihypertensive. So if you need to deal with her seizure risk, that's magnesium. If you need to deal with her blood pressure, that's your antihypertensive. There was a period of time where we worried about calcium channel blockers, particularly potentiating the effect of magnesium, but that's not been, although that's a theoretical risk, that has not been borne out in clinical practice. I also want to reply to Dr. Kusuma with your earlier question about, sometimes you see eclampsia in patients with a blood pressure in the 150 range. There are actually pretty decent data to suggest that 30% of patients who become eclamptic never mounted a blood pressure before the seizure in the range of above 180, and 15% were never hypertensive at all, defined as, a systolic of 140. Although often once they seize, and you treat them, then you see the hypertension. So again, you have to deal with two different things. One is your seizure prevention with magnesium. The other is your treatment for hypertension, and that's a series of antihypertensive drugs, whatever your choice is.
Thank you very much. And the second question is from our registrars. To Dr. Sarah, what are the most common risk factors that could be developed into pulmonary embolism and maybe eclampsia? Is there anything that we can prevent for pregnant women that hasn't in labor yet? Maybe a low salt diet or something like that? Any recommendations?
Okay, just to clarify, sorry, you mentioned pulmonary embolism and preeclampsia?
Yeah.
Okay.
Preeclampsia and eclampsia.
Okay. I'm sorry. Okay.
Sorry. I'm so sorry. Yeah.
Okay. Sorry, can you repeat that? Sorry, because I had thought you had mentioned it was pulmonary embolism. Sorry.
Sorry. What is the actually according to your perspective and your experience, what are the most common risk factors that could develop into preeclampsia and eclampsia? Maybe is there any possible way to prevent those things in women who's not in labor yet?
Excellent question. So I would say the number one most common risk factor, I would say, in my experience, is for someone developing preeclampsia is if she had a prior history of preeclampsia. And I would say there's lots of risk factors out there. Also, if the patient has a history of chronic hypertension, definitely she has a risk of developing preeclampsia. Extremes of age, so if she's very young, less than 18 or greater than 35 years old, that's a risk factor. If she has a morbid obesity, so BMI greater than 30, that's a risk factor for preeclampsia. If she herself was small for gestational age baby, so then she's at risk for developing preeclampsia. So yeah, there's lots of different risk factors for preeclampsia. But I would say by far, if she has had a prior history of preeclampsia or if she's a chronic hypertensive, definitely she's at risk for preeclampsia. And essentially, I would say the only thing that has, or one of the things that has been shown to reduce the risk of preeclampsia development is by giving baby aspirin early in the pregnancy, starting at around 12 weeks gestational age. So 12 to 16 weeks, essentially, we give baby aspirin, and that's been shown to help reduce the risk of preeclampsia. I would say in general, patients who are chronic hypertensives, it is beneficial to try to have their blood pressure better controlled going into the pregnancy. Also, patients who have obesity, if they can lose some weight prior to the pregnancy, those are also all other things that they can do to help reduce the risk of preeclampsia development. I believe, to my knowledge, and correct me if I'm wrong, Dr. Pines, I don't think that a low salt diet has been shown to be beneficial. I know just in general, the DASH diet in a chronic hypertensive in a non-pregnant patient has been shown to help reduce blood pressures, but it hasn't been shown in preeclamptics.
Right, so that's my understanding as well, that salt restriction doesn't help. In women who live in countries with a low calcium diet, increasing the amount of calcium in the diet can reduce the risk for at least prima gravidis. So that might be a dietary implementation you could try. There is also, at this point, there is a large randomized controlled trial underway in the US to see if pravastatin, one of the statins, actually reduces preeclampsia risk. So, tune in 3 years from now and have some more information for you.
Well, very interesting. Statins. Okay. Then we can wait until maybe approximately three years from now, and we can see the results. Then for you, Prof. Lauren, if we got a patient that comes with a previous seizure, but it turns out to be maybe happens few weeks before, and it's not showing any increasing intracranial pressure at the time of his hospitalization or the time of admission. Can we still do the spinal anesthesia? Because this is a very anesthetic question for it. Can we still do the spinal anesthesia for patients with a risk of seizure, but it happens last week, not today, or not when we got her in admission?
So that's not an eclamptic patient, because an eclamptic patient who seized a week ago has either a dead baby or has died. So that's a patient with a seizure disorder, or at least an isolated seizure. And the treatment for that is, evaluation of the structural integrity of her brain and anti-epileptic drugs. So in my opinion, you would be fine to use any anesthetic technique that you liked in a patient with a history of an isolated seizure or a seizure disorder, as opposed to an eclamptic seizure.
Well, thank you very much. It's very clear. And then we have another questions from our fellow students from Solo. If we have patients with severe preeclampsia and treated in the ICU, can we place some or administer some dobutamine or dopamine if the patient's got a shock condition due to heart failure? Can we still administer it, or we should little bit, maybe we change it to other agents? Dr. Sarah, perhaps?
Yeah, that's a very unique question, but yeah, I would say, to be honest, when it comes to preeclamptics, like, their blood pressure often, like, you'll see it skyrocket, we treat it, it comes back down, and then it may go back up again. I would say, in general, if she's hypotensive to the point where we are concerned, and like, where, let's say, systolics are in the 70s, and we're seeing this reflect on the fetal heart tracing, that's a situation where typically I would recommend using either like ephedrine or phenylephrine to help drive the blood pressures a little bit, because these are things that, at least in the United States, like our anesthesia colleagues have that readily available, because they often have that running or readily available when they're placing spinals or epidurals. Now, I personally would not go for dobutamine. Dobutamine decreases the systemic vascular resistance, so it actually will worsen her blood pressure, and especially for pregnant patients to begin with have a decrease in SVR, so it would not be my drug of choice. Dopamine, dopamine's very controversial, as I'm sure as you guys know. I don't love it. I typically only reserve that for heart rate, bradycardia, and to drive their heart rate up. But I typically would not use dopamine. I'll say my top three vasopressors I would use would be either phenylephrine, ephedrine, or norepinephrine. Basically anything to increase the systemic vascular resistance. But to be honest, it's very unique to see this occur. Like I think I would say I wouldn't treat a number in and of itself. Again, I think the fetus is an excellent marker of end organ perfusions. And so I would say the biggest thing that I would say, while if the patient is still pregnant with severe preeclampsia, is, again, we kind of have this universal goal, less than 160/110. Unlike non-pregnant patient where our goal is like a percentage, reduction, for us, it's just bring it down. Now we don't want to drop her to 90s over 50s, right? But I would say the fetus is the one that will tell us if we kind of overshot it. And I would say, so I would use vasopressor agents or vasoactive agents to just bridge for the fetus so that I don't have to do an emergency C-section all of a sudden now because of a terminal bradycardia in the fetus. But otherwise, I would say I otherwise would not go out of my way to use a vasoactive agent because it's pretty rare to have like a patient who's persistently hypotensive and symptomatic from it outside of the fetus.
And we have some information as far as blood pressure support in pregnant women at time of cesarean, and so I agree with you, Sarah. Norepinephrine would be the way to go. There's no use in dobutamine. There's no use in dopamine. So I would certainly, my threshold would be for norepinephrine, and we have some data to suggest that's your drug of choice in pregnant septic patients, although there aren't that many patients who are septic and still pregnant as opposed to septic and delivered. But yes, to norepinephrine.
Okay, thank you. Perfect answer. And next one is about to Dr. Sarah also. When actually this is very very often what we found in Indonesia. Not all hospitals could afford to get some IV like nitroglycerin or ISDN like isosorbate. So do you think or maybe we don't have labetalol. We could only have nifedipine, and sometimes we could ask for something else. But if there's somehow we cannot access that, is there any place for nitroglycerin or maybe isosorbate dinitrate for severe preeclampsia or for eclampsia maybe?
Excellent question. I'm trying to think of the effects, if it affects the fetus in some way.
We do, nitroglycerin would be fine. If you have a nitroglycerin, it's fine. It's a venodilator, and it will work.
Yeah.
Okay. And then there's also questions from Hendra from Surakarta. Is there do you have any recommendations from platelet transfusion for HELP syndrome? Do you have any specific targets? Something like that, maybe proflorin, because it's due to maybe some little bit of a management from
this is a fight we have on a weekly basis between the OB and anesthesia teams. So our general rule is that we think that a patient can labor safely with a platelet count above 50, and that certainly she can go to the OR with a platelet count above 50. We might let her platelet count be as low as 20 if we thought she was going to deliver vaginally and neuraxial anesthesia wasn't required. So the argument comes, what's the lower limit of platelet count at which you'd be willing to place a spinal or insert an epidural? And so, in an acute, so in a patient who has, for example, chronic ITP, right? So she has a chronically low platelet count and she runs about 90, and that's stable. I mean, most of our anesthesiologists are okay with neuraxial anesthetic at that point. But in a patient who has sort of an acute process like HELP syndrome, that's not most of our anesthesiologists, in your practice may be different, are really not comfortable, if you're down below 6 significant digits. So if you're down below about 100,000, she's going to tough this labor out without an epidural. And if she needs to go to the OR, she's generally going to go to the OR under a general anesthetic, which is still pretty rare in the US. I would be interested in hearing your practice.
Thank you. Well, before we go into some breaks, last questions. This is from our registrars. He would like to ask, after the treatment with, ABC resuscitation and magnesium, and the patient's vital sign is stable, should we still concern about the intracranial pressure? Or maybe we could try to use ultrasound, maybe optic sheet diameter, or maybe transcranial Doppler when it's available to check maybe how many hours each. How about how likely to be it's possible to do it?
I think this is an excellent question. So first off, I think post-eclamptic seizure, this is a patient who should go to the ICU just for Q1 hour neuro monitoring. So for Q1 hour neuro checks. Second is that anyone with an eclamptic seizure, typically we want to get some form of brain imaging at some point once she's stabilized. Now, this is not a situation where while she's actively seizing, we have to push her, to the CT scanner. This is just once things are stable, to get some imaging to see if there's any other organic cause to her having the seizure. So I personally love point of care ultrasound, and I love using optic nerve sheath diameters as a surrogate marker of intracranial pressures. However, this is not something that I think is universally has been established, so we could definitively say if it is increased, then that correlates. I think I can't imagine a clinical scenario where I would not get brain imaging, and I would say ideally MRI is more ideal, just because it could show obviously more detail, but especially for Press syndrome or posterior reversible encephalopathy. I mean, although you can see that on CT, MRI will show that better. So.
Thank you very much for your answers. We can continue to our break, maybe about 5 minutes until 6 minutes. We take a break first, and then we can continue to Dr. Burhan, to the IT team, and I give it back to you. Thank you. Dr. Burhan?
Izin kami kembali.
Thank you very much, Dr. Burhan, for your kind introductions again for the second session of our meeting, our guest lecture. Before we start with the next presentation by Dr. Burhan, one of our esteemed registrars, I would like to say thank you first to our esteemed sponsors from PT Aku Scientific Indonesia. Thank you very much for also joining in our next third ISMOAC 2024 that will be held in July, from the 1st of July until the 6th of July in Jimbaran Convention Center, Jimbaran, Bali, Indonesia. Don't miss it. Please join us, come and join us. It will be much pleasure for us. There would be plenty of lectures from esteemed speakers, professors. Sarah would be there too. And we would have a little bit party also afterwards. So don't forget to join us in the fun of ISMOAC, while we could learn and also have fun at the same time. Okay, so now I would present our next presenter, Dr. Burhan. Burhan is one of my esteemed registrars. He also helps us in the quite often guest lectures, one of the IT department divisions, and now he's in it. What semesters are you? Fourth, fifth,
Third semester.
Oh, third. Okay.
Yeah.
Now, this will. Okay. So now let's begin your presentations. Thank you, Dr. Burhan.
Thank you, Dr. Sindri, for presenting me. So today I'm trying to share one of the case that we had in our intensive care unit. I'm not so sure that I'm going to explain from minute to minute, because we know that actually to manage a patient in an intensive care unit, you have to have a close monitoring. I mean, like you have to know time by time, I mean, like maybe seconds to seconds. But I'm trying to show one of the case we get here. It is a case of amniotic fluid embolism, which causing the patient to have, be cardiorespiratory arrest, and then she is being resuscitated and then roasted, and then she can discharge at the 6th day after the treatment in this hospital. So slide. Before we go into the presentation, I'm just going to give some introduction that this amniotic fluid embolism is a kind of a life-threatening obstetric emergency, which is characterized by a sudden cardiorespiratory collapse and disseminated intravascular coagulation. It is well known for it is a pro-inflammatory anaphylactic blood reaction that can occur when the amniotic fluid enters the maternal blood circulation. Usually patient in this condition, it is a abrupt condition and then causing the sudden cardiorespiratory collapse followed by a severe coagulability and refractory resuscitation. Next. For the incidence and the prevalence, it is estimated it is a 1 case per 8,000 to 30,000 pregnancies. Well, actually, the exact prevalence is not known due to the inaccurate diagnosis and because some of the cases is not reported as an amniotic fluid embolism. Maybe it is because some kind of rare condition. So not all of the general physicians or maybe the OBGs in this country to check to make sure the diagnosis. And actually in the United States, this condition occurs in 2 to 8 per 100,000 deliveries, and it is the cause of maternal mortality between 7.5% to 10%. And in Germany, it was the leading cause of death during parturition. And in the UK, it is estimated that the incidence is 1.9 per 10,000 to 7.7 per 10,000 births. Right? And as the etiology, as I've mentioned before, that amniotic fluid embolism is quite unpredictable. When the fetal cells entering the maternal circulations, whether by any kind of the condition, whether liberation of intense inflammatory cytokines return to the foreign material, it will create an intense pulmonary vasoconstriction and a bronchoconstriction. That's why it is one of the conditions that cause the respiratory arrest. And then the inflammatory condition will cause the trip of the coagulation and fibrinolytic pathways and causing the severe changes in the mechanism that affects the blood clotting. And it will cause DIC, and then it will have the serious bleeding. The systemic inflammation develops in response to the action of systemic damage factors pronounced in intensity. Initiate a complex of interrelated process, including pro-inflammatory transformation, in which it will activate the intravascular complement, hemostatic, and all of the inflammatory systems. The microcirculatory disorders are the core of the systemic inflammation pathogenesis, manifesting as the complex set of resuscitation syndromes, including the DIC, vascular shock, and then the acute respiratory distress syndrome and the MODS or multiple organ dysfunction syndrome. Yes. And the pathophysiology is not quite understood, but there are some theories. The first is the disorderly labor, abnormal placentation, or maybe the surgical trauma or any other breach of the barrier between the maternal blood and the amniotic fluid. It will cause a pressure gradient transfer fluid from the uterus into the systemic circulation. And this will cause the physical obstruction and the pulmonary circulation. Slide. The entry of the amniotic fluid into the maternal circulation, it will activate the inflammatory mediators, whether it is a humoral or immunologic response. And actually, the amniotic fluid contains vasoactive and proagulin products, including the platelet-activated factor, cytokines, and then bradykinin, thromboxane, leukotrienes, and arachidonic acid. The concentration of this tissue factor and tissue factor pathway inhibitor, it will trigger the DIC, and actually it is more higher in the amniotic fluid rather than in the maternal serum. And then the maternal plasma endothelin concentrations are usually increased by the entry of the amniotic fluid into the systemic vasculation. It will cause the bronchoconstriction and then pulmonary and coronary vasoconstriction, and it will cause the respiratory and cardiovascular collapse. Slide. As I've mentioned before, that the complement activation, whether it is C3 or C4 activation, it will cause the release of histamine and tryptase, causing an inflammatory response. And the initial reactions begins with a transient pulmonary vasospasm, and then it will trigger the release of arachidonic acid metabolites, and it will lead to a pulmonary hypertension, intrapulmonary shunting, bronchoconstriction, and severe hypoxia. The negative introphism and left ventricle failure, it will increase the pulmonary edema and then hypotension, and it will quickly leading to a shock. And the third manifestation in the in these neurological responses, it can cause seizures, confusion, or even the loss of consciousness into coma. Next. This is the pathophysiology. It explains what I've mentioned before. Continue. We know it as an early phase and a late phase. We usually know it as the obstetric shock, and then there is a cardiogenic shock, hypothalamic shock, and then it is a distributed. So mixture of these 4 types of shock is found in this anaphylactic syndrome caused by this amniotic fluid embolism. Next. The disruption of the maternal and fetal interface of the potential passage of the amniotic fluid into the maternal circulation, it will cause the increased level of pulmonary vasoconstrictors. It will cause the acute respiratory failure with severe signs, severe hypoxemia, and then amniotic fluid can also activate the 7th factor and the platelets with consequent DIC, inflammatory response, and it will causing the clotting cascade, causing this hemorrhage, which will be contributing to the hemodynamic instability. And then the increased level of the pulmonary vasoconstrictor also can cause the acute right ventricular failure, which is causing the hemodynamic collapse from high ventricle infarct and the intraventricular septum displacement. Next. There are some kind of short introduction before we get into the case presentation. This case presentation is a female, 29 years old. She is having her 3rd pregnancy, and she right after the sexual cesarean deliveries, she went into a cardiorespiratory arrest, and by the OB/GYN, it is diagnosed as the suspect amniotic fluid embolism. Next. A short history taking before the admission. The patient was admitted in 14 December, but in the 9th December, the patient has last antenatal care. She came with a complaint of contraction, and after the antenatal care, the OB/GYN suggested that if there is any another signs of contraction, she is referred to the hospital, and then she will be assigned to having the cesarean delivery. And this patient also has a surgical history twice before, and it has the twice cesarean before in 2018 and 2020. And her last menstrual period in this the 3rd pregnancy, it is 29th March, and it is estimated due date in 5th January. So in the 14th December of 2020, the patient came at around 11 a.m. With signs of contractions, but no bodily sign and a normal fetal movement. But then the patient was suggested for C-section, and at the 3:25 p.m. the C-section was started, and then the baby was delivered at 3:32, and right after the placenta was delivered, the patient was having cardiac arrest. But before she has the bradycardia, and then showing the signs of hypoxemia. And after the 3 cycle of high quality CPR followed by the ATT intubation, the patient is resuscitated, and then the operation was continued to closure of the abdominal wall. And all of the operation was done in 5 p.m. and then the patient was admitted to the ICU. And after the patient was admitted to the ICU, the patient was decided to be referred to our hospital, Professor Ngurah General Hospital, since there is some technical problems over there in the previous hospital. Next. I'm trying to relate it, what kind of the risk factor that we have in this patient, and with the reference that I have found before. And the risk factor of the development of the amniotic fluid embolism is the first is advanced maternal age. Some literature say that it is above 35 years old. Some said that it is above 40 years old. And the multiparity in this patient, it is the patient has this was her third pregnancy, male fetuses, and in this her last pregnancy, she gave birth to a male fetus. Trauma, induction of labor, which is not happened to this patient, woman with cerebrovascular events, and then cesarean delivery, this which is one of this patient risk factor. Placenta previa, eclampsia or preeclampsia, placenta abruption, polyhydramnios, dilatation, and curettage, also with the renal disease. But only 3 of these risk factors was found in this patient. Next. The signs and symptoms that usually is found in this kind of situation is amniotic fluid embolism. The first, the symptoms is dyspnea, and then cough, and then the headache, and then chest pain, which is signs of the hypotension, fetal distress, pulmonary edema, cardiopulmonary arrest, stenosis, coagulopathy, seizures, and so on. Next. And in this, some of the diagnostic criteria, one of the literature, I have found some kinds of few diagnostic criteria. The first one comes from Haftel and Chowdhury. There are 4 criteria: acute hypotension or cardiac arrest. The second is acute hypoxia. The third is a coagulopathy or severe hemorrhage in the absence of other explanation, and all of these occurring during labor. So all of this must be found in a patient to diagnosis a patient with AFE. Next. This is also few criteria. There are the US criteria, the UK criteria, and Japan criteria. Most of them looks similar. And in the US, it will just like the before criteria, the acute hypotension or cardiac arrest, acute hypoxia defined by dyspnea, cyanosis or respiratory arrest, coagulopathy, and then the onset above during labor and absence of any other confounding condition. In this patient, we found all of this, whether it is in the US criteria or UK criteria or Japan criteria, all of these are found in the patient that we are talking. Next. In this patient, the patient was documented for having dyspnea right after the baby was delivered. Right after the placenta was delivered, coughing, and then had a sudden loss of consciousness. First, the patient was bradycardia, continued by acute hypotension, and the patient was documented for having given 2 m's of sulfasalazine, but it didn't respond, and so she went through a respiratory arrest and cardiac arrest. Next. From the laboratory tests, which is usually we do, but maybe sometimes we didn't focus on this because we have never really think AFE as one of the cause in the amniotic fluid embolism. In the complete blood count, we can find the low hemoglobin, and then the low platelets increase. Also for the coagulation factor, we can find increased prothrombin time, activated prothrombin time, and then low fibrinogen. And from the ABG analysis of the blood gas, and then we have find the hypoxemia and a raise of carbon dioxide pressure. And then from the CSR, we can have cardiomegaly or pulmonary edema. From the electrocardiogram, you can see the right heart strain or rhythm abnormalities. Echocardiogram, you can find the rate of left ventricle dysfunction, low ejection fraction, and some of the other specific tests like a pulmonary blood sample, cell antigen, which is I'm not really sure if it is being done here in our hospital. Next. So in this patient, what we found is the patient doesn't have the low hemoglobin, doesn't have the low platelet. Next. The hemostatic function was normal in the very first place. The prothrombin time was normal. In its international normalized ratio was also normal. The activated prothrombin time was also normal. But right after the operation, right after the surgical was done, we found that there is an increase of D-dimer. So this is the number after the operation was done. The CTBT was taken, the clotting time, the bleeding time was taken before the surgical. This proton time, the international normalized, and the APTT is taken after the surgical. Next. And the liver we found in this patient the liver function 10 was elevated, but I do not find any other literature which show that the elevation of the liver function in the AFE condition. The renal function was normal, and then the immunology from the immunology we found that the procalcitonin is a bit elevated. Next. And this is the blood gas analysis right after the patient was moved to our hospital with slightly acidosis. Next. This patient was done electrocardiogram on the first arrival day in our emergency ward. We can find that it is actually a sinus tachycardia, which is no signs of right ventricular strain, or just like the literature said before. Next. And this is also on the discharge day, right after 6 days after the patient was extubated, and then the patient was then moved to the ward, and then the patient was discharged at the 6 days. So there is no signs of changes in the electrocardiogram. Next. This CSR was taken right after the patient was sent to our hospital. The CSR was taken twice. The first is on the 14th, and then the next is 16th, 3 days after being treated in our ICU. The first day, it's shown that there is the pulmonary edema, and then the next 16 December, it is more sure that from the CSR is a pulmonary edema. So the cardiac is normal, and then there is no other signs of any other abnormalities. Next. This is the comparison, which shows that the patient is getting better by the CSR evaluation. Next. In this patient, it's unfortunately that we do not do this examination. I have tried to contact the previous hospital who referred to us, but still they also didn't do this histological confirmation, which is actually one of the gold standard in making sure whether it is really the cause of the cardiac arrest or to the condition to the patient is because of the AFE. This is the picture if we are having the histopathological examination. It can be drawn from our blood, and then there is a signs of the fetal squamous cells known in our maternal veins. Next. This is another fibrin clottings. Next. And the management of this AFE is usually first when we suspected AFE, because of course we cannot make sure until, to make sure whether it is AFE cause or something like that. The first thing we need to do is the resuscitation. So consider the immediate delivery, and then we do the resuscitation, but during the resuscitation, we need to avoid excessive fluid resuscitation. And then we need to consider the norepinephrine to maintain the blood pressure, and then to make sure that whether the right ventricular failure is addressed with inotropes such as dobutamine. And then the second phase is characterized by the left ventricular failure and the cardiogenic pulmonary edema, in which we should maintain hemodynamics with the use of norepinephrine and inotropes such as dobutamine, and we need to limit the excessive fluid administration. And we need to examine the coagulopathy function, and if needed, we need to activate the massive transfusion protocols. Next. This is what I've mentioned before, that the first step of the management of this condition, because the patient, the condition is usually abrupt and causing a patient to have cardiorespiratory arrest. So we should immediately give the high quality CPR, and then the involvement of the multidisciplinary team, including anesthesia, respiratory therapy, and critical care. And then we use the vasopressor, and then we also we need to, following the cardiac arrest with AFE, we recommend the immediate delivery in the presence of the fetus above 23 weeks of gestation. This is usually if we found not during the delivery process. Next. And in this patient, after the cardiorespiratory arrest, the patient was intubated with 7.5 cuff ETT, and then continued with 3 cycles of high quality CPR with 3 amps of epinephrine. And then the patient showed sign of ROSC, and the closure of the terminal wall is continued. And then the patient was admitted to the ICU and connected to the ventilator. Next. This was the medication from the previous hospital. Next. And the post-cardiac arrest management that we need to focus on is the using of the fluids, and then the vasopressor inotropes to maintain MAP above 65. And then we should avoid fever, and then we should avoid hyporexia also. And then we should maintain the pulse oximetry value between 94 to 98%, with the inspired fraction shouldn't be too high for a long time. And then the serum glucose also should be maintained between 140 to 180, and even if using of the insulin is needed. And then we should make the patient with mild therapeutic hypothermia, defined as a cooling the patient to a temperature between 32 to 34. Next. And in this patient, the patient was controlled and connected to the ventilator for 3 days. I mean, 3 times 24 hours. The first day the patient came was the patient was connected in the mode of patient PCB PEP, and then the fraction was quickly weaned from 100% to 60% in the first 3 hours. And then the next day was we tried to wean it again to 40%, and then the patient was then extubated in the 17th December. I also shown the fluid balance. The first day, it looks like the patient was too much fluid, but then in the next few days, the patient we keep the patient with the balance of negative, and then the patient was we make sure that the temperature is normal, and then the blood sugar also maintained. We check it every day. Next. This shows the ventilatory setting. Next. We also do the energy blood gas every day to make sure whether our ventilation is given correctly. We responded for every time the blood gas was taken. We responded by changing the fraction, and then the respiratory rate. Next. As what we mentioned before, that the management should be focused on the hypoxia, acidosis, and hypercapnia should be avoided, as they will increase the pulmonary vascular resistance, and it will lead to further right heart failure. The adequate oxygenation and ventilation, and when indicated by hypodynamic status and the use of vasopressor and inotropic agents in the initial management of aneurysmic fluid embolism. The excessive fluid embolism, once again, should be avoided. Next. And in this patient, the patient was having the CVC-SS in the second day, 15 December, and had the close monitoring of central venous pressure, and then the blood pressure, heart rate, and IVC. We do this as a close monitoring. We maintain the CVP. You can see that we keep it normal from every day from when she is getting treated at the ICU, and the blood pressure 88 to 100 as what is shown in the table. IVC was also we every time we you see that if the patient shows signs of the IVC distensibility is needs some fluid, we'll give fluid and it will still respond. Thank you. Next. This patient also was consulted to our cardiologist, and they do the echocardiography, which with the conclusion of the dimension of the heart chambers are normal, alveolar concentric remodeling with ejection fraction of 57%, normal left ventricle diastolic function with normal right ventricle contractility, hypokinetic basal mid inverse septal, basal mid inferior with the TR mal and ERAP of 8, and then no McConnell sign, and no 60-60 sign. Next. This shown our what we do after we check the IVC, after we monitor of the blood pressure, the heart rate. When this is one of the example when we found that the patient has a low urine output and then the low blood pressure and then the IVC distensibility is 37%. We try to do loading of crystalloids in 50 minutes, and then we recheck it again. We measure the CVP, we measure the IVC, we measure the blood pressure. And once the patient was getting into the impending shock condition, which is after we have using, because in the first day, we found that the fluid balance was kind of positive. So we do the furosemide, and it caused the patient to have a low blood pressure, and then we adjust it. We just give her the dobutamine and norepinephrine with a target of MP of above 65. Next. Next. Yeah, this is the monitoring of the patient. Next. And the prognosis usually after the AFE is very poor. Most women do not survive. If patient survives the embolism, most survivors have neurological deficits. The infant survival rate is about 70%, and the neurological status of the infant is directly related to the times elapsed between the maternal arrest and the delivery. But in this patient, unfortunately, the maternal arrest was happened right after the delivery of the infant and the delivery of the placenta. The risk of recurrence is unknown, but the successful subsequent pregnancies have been reported. Next. The survival after this condition improved significantly with early recognition of this syndrome and early resuscitative measure. Previously, it is documented that 50% of patients will die within the first hour and about 2/3 within the 5 hours of the event, with a high incidence of severe and permanent neurological damage among the survivors. The respiratory failure with non-cardiogenic pulmonary edema and the refractory bronchospasm are the reported sequelae. But in this patient, next. This patient, the patient was resuscitated and then discharged from the hospital 6 days after being admitted to our hospital, had her first follow-up 7 days after her discharge with no neurological deficits, and were referred to the cardiologist for her next appointment. The infant was delivered successfully at 14th December with a body weight of 3,200 grams, the Apgar score of 8 and 9, and being discharged at 15 December at the Primagana at the previous hospital. Next. Okay, I think that is my presentation. Thank you for the time.
Thank you very much, Dr. Burhan. Very excellent presentation, and also it's very compact, and also it's such an interesting case. It could happen to anyone. It could put a panic in even a mature anesthesiologist would be stressed out if they found about this. I would like to ask for comments from Prof. Lauren first, and then Sarah. What do you think of this case, and how about our management and therapy? Could you put something, and then maybe add some suggestions, add some comments, and everything else? Maybe Or maybe is there anything that we missed, or maybe some delayed, or maybe missed in diagnostic and something like that? Please, Prof.
I am reminded of something a professor of mine once said, and that is, if you diagnosed AFE and your patient survived, you were wrong, right? I think in this particular case, you have a live patient, and so you did a good job. If I could ask for some clarification, though. Her event happened at the time of cesarean delivery after the placenta was delivered, right?
Yes,
Yeah.
yes.
And I think in this circumstance, it's useful to consider that venous air embolism may actually have been the inciting event rather than amniotic fluid embolism per se, right? Because you can find fetal elements in maternal circulation in every pregnant woman if you look hard enough. And the whole concept of AFE as a diagnosis it's just fraught with so much difficulty. And I think, certainly if you have a cesarean delivery, they exteriorize the uterus to deliver the placenta and do the repair. I think that predisposes you to a venous air embolism. And therefore, in this situation, if I had this, I'd have flooded the surgical field, right, with saline and changed the patient's position while doing all the other things that, you would describe as being done.
Sarah, probably. Any additional comments?
Yeah, great job, guys. I mean, clearly you resuscitated her very well. I would say, yeah, I guess just with AFE, I know it's something it's hard in the obstetric literature, as Dr. Plant was mentioning. Like in real life, I think nobody really gets fetal or like the blood to assess for fetal parts in circulation. And I know Dr. Plant mentioned even if we checked it, we often see it, and so, whether for me, the way my mindset goes is like whether amniotic fluid or venous or whatever, I just treat this as very similarly to just any sort of massive embolus, right? So like in my mind, I kind of think of it as like, let's say this is a massive PE, essentially, that's often manifested as, first acute right heart failure, which then can lead to acute left heart failure. So, Burhan did an excellent job, describing that, you want to fluid resuscitate them, but you want to be judicious because, if you overload them, they will third space everywhere. And so, yeah, basically, essentially volume, but being judicious with it. And then you want to think about things, if she is, not necessarily responding to it, that will decrease the right heart pressures. So, considering either milrinone, which we know it decreases pulmonary vascular resistance, dobutamine, or inhaled nitric oxide. Obviously, this is difficult to do in the very acute setting, in the setting of like CPR and things of that sort. But this is like after the fact, if we're still having difficulties, maintaining her blood pressures. And then I would say, for a patient like that, especially with an X-ray that looked like that, I definitely would aggressively diurese. So I think it was great that you guys, diuresed her. But typically these patients often will need diuresis, and even in the absence of like their X-ray manifesting, overt signs of pulmonary edema, I find that just regardless, the physiologic mechanisms is like increased right heart pressures, whatever it is that's embolizing. And so I find that like just diuresis will always help decrease the pulmonary vascular pressures. I tend to like to be able to diurese them a little bit more on the aggressive side. And yeah, I think that's pretty much it that I could think of for now.
Thank you very much. So based on your perspective, I think this is much more like maybe venous air embolism, or maybe a little bit pulmonary embolism involved inside of that.
No, I don't know.
Or maybe just
I have trouble with the whole
hypertensive.
concept of amniotic fluid embolus, because the original sort of animal data on amniotic fluid embolus came when researchers took amniotic fluid from rabbits and injected it into rats, and they had a sudden cardiovascular collapse. But that wasn't because it was amniotic fluid. That's because it was foreign antigens, right? And so we don't, Dr. Burhan did, I think, an excellent job of laying out what we do and don't know, but we still don't actually understand what this entity is that causes a sudden cardiac and respiratory collapse, generally followed by a coagulopathy, and we don't understand what it is. it almost doesn't matter though, if your patient has a sudden arrest, you know, at the time of cesarean delivery, or for that matter, you know, in labor, you're going to do the same things regardless. Right. So you're going to carry out whatever your appropriate life support interventions are. And then the etiology of it, you're probably never going to know. You're not going to stick a pulmonary catheter in and you'll aspirate some maternal blood and send that to the lab to look for squames. Because if you don't find any, it doesn't tell you anything. And if you do find anything, well, okay, but was that the incident? So I think we shorthand this as an entity, when really what we should be doing, I think, is to treat, you know, the cardiac arrest, which was done. And then she had very appropriate, you know, post-resuscitation care.
Thank you. Sarah, any further comments? Yeah.
Yeah, I'm just trying to think, you know, like how should we treat this differently outside of the right heart physiology that I mentioned earlier? Well, I would mention, like, first, traditionally, they often describe that, like, these patients often have, like, acute altered mental status or an impending sense of doom. And so I guess as an anesthesiologist, if you suddenly, you know, have a patient, which is hard because, like, a lot of people have impending senses of doom just in general during delivery and so forth. But yeah, just in general, like, it's just something to keep in mind with this. I think also the classic, like, pentat that they often say for, like, amniotic fluid embolism is, you know, altered mental status, hypotension, hypoxia, and DIC. DIC is absolutely necessary for the diagnosis of it. So it's something to keep in mind. Lastly, I'll just mention, I know there's like some literature out there that this describes treatment with something called AOK, or atropine, ondansetron, and Toradol. And so essentially, basically, there have been, like, case series that demonstrated in women who have sudden cardiac arrest, and essentially they had, like, CPR in place for a prolonged period of time, and then after they were not getting ROSC, and essentially after pushing atropine, ondansetron, and Toradol, that, like, ROSC occurred shortly after. The reason for that, and you may wonder why, it's like kind of like a random combination of things, but essentially they described that, like, and Burhan did a good job, like, describing a lot of these, like, physiologic mechanisms, but essentially as part of the physiologic cascade of this fetal material embolized to the pulmonary vasculature, involves a release of bradykinin and serotonin, and so essentially oftentimes you may see that the patient may be brady prior to arrest, and so that's why the atropine is given. Ondansetron is given usually 8 milligrams IV. By the way, for the atropine, it's 1 milligram. Ondansetron may be given, it's usually 8 milligrams, and that's for the serotonin release that ends up causing the cascade of, just lots of different mediation. I can't remember all the different chemicals involved at the top of my head, but basically it's to address the serotonin aspect of things. And then last is Toradol, and then also that is given for similarly these chemical cascades that is involved with the embolization of the fetal material. So there has been a push, you know, some institutions carry this as part of their OB crash carts, and I think the cost of all these items are relatively cheap. I think I saw some literature saying it's like less than $10 to have all these things stored in the code cart. So it's one of those things, in my humble opinion, I personally haven't experienced this firsthand. In my mind, I think this is someone who has arrested, they're not alive. At this point, anything can help. And I think it's relatively a benign intervention, giving some Zofran, giving some atropine and Toradol, I think. So I personally would advocate to try it. It doesn't hurt in my mind. So
thank you, because you mentioned those cocktails, because I have those questions around that in the comment section, but thank you for answering it. This is minimizing my job, but okay, thank you. But the cocktails AOK, like what you said, the atropine and the Toradol, like we're not familiar with it. It's uncommon in our practice, but thank you. But because that's might be another options for at least to manage this kind of patient. How about increasing the blood pressure before our treatment? For Professor Lauren, do you think about it? How can we increase the MAP before the sudden drop due to the physiologic cascade and everything? And maybe any specific interventions that we could do before those things could possibly happen?
I don't think I understand the question.
I mean, if can we increase the blood pressure before the regional anesthesia? Let's say that
Certainly, your
this
anesthesiologist, you can make the blood pressure be whatever you want it to be. But is the question whether that would change the predisposition to this sudden collapse? Is that the question?
yes, yes, the sudden collapse, and also because the participant is asking about the increase of the MAP could potentially leads to another backflow, especially in patient with a right heart kind of failure, but not yet. Do you think we still could get another higher MAP, or we just do the baseline thing?
You mean as a therapy? I have no data to answer that question one way or another. If your patient hasn't arrested yet, your calculus for the risk is different. If your patient has, as Sarah said, you know, like memorably, I mean, if your patient's dead, you can do anything because you can't make her any worse. But if your patient isn't dead yet, you have to consider the cost of the intervention, whatever it is. So if you thought something bad was maybe going to happen, should you increase her blood pressure? I mean, most of us don't have that degree of premonition. Most of us can't see that coming. So I think that would be hard to affect.
Okay, so no evidence available to at least to rectify those things. So we don't know. We may know, we may not know what happened next. So, but do you think it's recommended or not to increase a little bit the MAP before we do some spinal anesthesia?
So you mean sort of preventively, you know,
Yes.
do you, okay.
Yeah.
So sure, if your patient is, you know, is hanging out with a fairly low blood pressure and you're planning something that's going to cause a sympathectomy, sure, you could, you know, preventively, you know, infuse some phenylephrine or ephedrine or whatever it is you like. I remember one attending who used to, in his local, before he inserted the spinal needle in his local, he mixed a little bit of a vasoconstrictor. So there was like a slow subcutaneous absorption. So sure, I mean, I think that if you're worried about the effect of sympathectomy in a given patient, sure, you can take some measures to prevent a significant sympathectomy. I don't see any reason not to do that.
Thank you. Sarah, any potential comments on it? I mean, maybe what could happen in the critical care settings, even if after the patient is survived? What do you think? Should we increase a little bit the MAP?
So yeah, I think, let's see. I think as Dr. Plant mentioned, I think when it comes to like AFE, when it acutely happens, there's like, I think one of the classic constellations is that this happens so acutely, there's no forewarning that this is going to happen. So I don't think this is something that can be preventatively done. Now, I think like post ROSC, I personally don't think that there is any evidence to support that. I think similarly, you know, I'm trying to think of like just in general post cardiac arrest patients, there isn't any evidence to suggest that like, you know, increased MAP therapy can benefit like neurologic outcomes. The only thing that I will say that I would focus on is like, you know, if she doesn't have return of neurologic function back to her baseline, I would recommend cooling this patient, just like any other cardiac arrest patient, in terms of doing targeted temperature management to help improve her overall neurologic outcomes. But sorry, yeah, sorry to digress a little bit from your original question, but yeah, I personally would not increase her MAPs any further. And yeah, I personally wouldn't.
Okay, thank you. I think we could say that it's done for this case presentation. I would like to retract back to several questions that not being answered yet, but maybe we could let's say we could focus on a little bit on the maternal hemorrhage first, because well, lots of questions regarding the hypertension and everything. There's a question that regarding about the ARDS in case of patients with a massive transfusion protocol. What are your comments on this, Professor? did the massive protocol still could be used for this patient, or should we do some restrictive protocol, or maybe we could use some diuretics?
So if you're thinking about, acute transfusion-related overload, that's relatively easy to fix, right? But if you don't correct the hemorrhage ahead of time, you don't have anything to fix. There is a question about TRALI, right? Transfusion-related acute lung injury, about how to prevent that. And interestingly, your blood bank will have the answer to that. If you think a particular patient is at the donors who are most likely to give your patient transfusion-related acute lung injury are actually blood donors who are multiparous women. So if for some reason you were particularly worried that your patient was going to develop TRALI, you would say to your blood bank, only give me blood products from male donors. But TRALI, transfusion-related acute overload, is relatively easy to treat. And I would say you treat the hemorrhage first, and then if she has a complication from your transfusion, that's a separate issue. You deal with that next.
Sarah, any specific interventions?
Yeah, excellent question. I agree with Dr. Plant 100%. Yes, definitely. You need to treat the hemorrhage first. So I would massively transfuse. I wouldn't alter a single thing based off the fact that, like she has increasing oxygen requirements. Just as just a few days ago, actually, in my cardiothoracic ICU, I know it's not an obstetric patient, but I had a patient who had a severe aortic dissection, and he received 24 liters of blood products, 24 liters. By the time he came to my ICU, he was alive and brain functioning, organs functioning, anesthesiology team did a phenomenal job resuscitating this patient. But of course, his people's like 10, 12, F2 was 100% by the time he got to me. So I was aggressively diuresing him. And now he was actually extubated 4 days later. So yeah, but absolutely he wouldn't have been alive had they not done massive transfusion protocol. And so I definitely would not restrict it in that setting. I would say, let's say the oxygen requirements are coming to a point where it's actively like if they're maxed out, like FL 200%, P 10, 12, peak pressures are very elevated, you can't go any higher. During the active resuscitation, I would consider, a few things. One, is it like abdominal compartment syndrome contributing towards this? But also, I would just like push Lasix at the same time, or furosemide and some diuretics at the same time while still resuscitating. Because, if the patient's not going to survive without the blood products, or will have significant effects by not being resuscitated appropriately with the blood products. So I would still maintain that priority while administering diuretics.
Thank you very much. And this is quite ethical and quite political, but we have spoken about the clinical judgment, clinical diagnosis, clinical therapy. How about the roles of each of us as a collaborative, or maybe some like a coordinating teamwork between OBGYN, critical care intensivist, neonatologist, and what are the roles of each of them in your perspective, or maybe in your experience in your hospital? What do you think of it? Because you're coming from a dual background. So what do you think of it, Professor? Or Sarah, maybe.
Yeah, I'm happy to take that. So I work full-time in the ICU, and I work part-time as an OBGYN hospitalist. So, I see an interesting mix of what it's like being on both ends. I think, every single member of the team is absolutely critical. And I think good communication is absolutely key. I think one of the main things I think I appreciated after doing my critical care fellowship is, how sometimes often surgeons are not the best communicators when we're actively hemorrhaging. And so communicating that with our anesthesia colleagues to make sure that, they're able to adequately prepare, resuscitate, as we progress in the case. I think also anticipatory guidance is absolutely critical. So for example, when I'm in my OB/GYN role, before any emergency section, let's say it's a patient with like preeclampsia or whatever it is, that's a patient with a higher risk of hemorrhage. During the timeout, I discuss these things. And so I announce it to the room, this patient does have a high hemorrhage risk. I would like TXA to be given after delivery. I would like to have 2 units prepared and cross-matched in the room, and I would like to have methogen drawn and on my sterile field so that I could give it intramyometrially, or things of that nature. So I'm big on anticipatory guidance also, and I try to be mindful. Although I can understand sometimes when we're deep in the surgery, we kind of forget to say things out loud at times. But trying to really maintain that open line of communication.
Professor, any any difficulties of coordinating between both or several worlds?
Right. So most of your patients who end up in ICU, most of your OB patients who end up in ICU, probably certainly over 60%, possibly as high as 80% get their postpartum, either because whatever happened to them happened postpartum or because delivery was part of the treatment, right? So that for your eclamptic patient, you can't treat her without delivery. So most of them end up in the unit postpartum, and most of them are there for only a pretty short period of time because most of them just need higher acuity monitoring as opposed to life support interventions. So in those cases, the role of the neonatologist is almost nothing other than ensuring that the mother and the family has some idea how the baby's doing. But the surgeon, the obstetrics team, and the anesthesia intensive care team really have to have a sense of what each other is doing. And it's my experience, the anesthesia team knows more about what the surgeon is doing, and the surgeon has no idea what the anesthesia team is doing. And so sometimes you just have to say politely what it is that you're doing and why, because you know more about their job than they know about yours. And not to be rude about it, I've stood on both sides of the surgical drape. And you know that it's easy to be unappreciated on the anesthesia side. If things are happening in the OR when the patient's actively delivering or the patient's having a cesarean delivery, then honestly, for your patient who has something major happen, certainly for a patient who arrests in the operating room, her chances of survival, if she has an arrest at time of C-section, her chances of survival are higher than anybody else's because everybody you need in the team is right there, right? So all of your life support interventions, all of your personnel, everybody's right there. So for people who have an anesthesia-related arrest, survival's over 90% because you know what to do, it's right there. But sometimes the transfer of leadership for whatever the given situation is can be politically difficult because there are sometimes some fragile egos involved. If the issue is bleeding and it's a surgical bleed, the surgeon ought to know what to do, and your job is just to support. But if the issue isn't a surgical fix, right, then the person who has a better idea of the physiology is probably better positioned to lead the efforts, but you gotta be able to persuade your opposite.
Very interesting opinion. I can't wait to employ it. We'll try. Are there any specific procedures, or maybe like like a joint guideline, joint like a group of discussion between 2 worlds, 3 worlds, anesthesiologist, a critical care, or maybe neonatologist? Do you recommend so, or should we just stay with some, I don't know, specific task force, or just a regular thing?
So I think after you have a major event, it's important to debrief it, right? So it's important to get all the people from all of the relevant teams in one room. Patient stabilized, the patient is taken care of, but you need to go through what happened. So I think the debriefing is important, and I think nurses are also part of this debriefing process. And then certainly if you see a potential disaster coming in your general direction, so you have, I don't know, a placenta accreta, and you know that you're going to have to deliver her 2 weeks from now, you sit down and you make a game plan far enough ahead of time. The issue isn't the ones that you can see coming. The issue is the one that catch you with your pants down, right? You weren't expecting it. And so now what do you do? And so that's the utility of having a team that's worked together and having some protocols in place and having debriefed the last few times that something happened, because there's always lessons to be learned.
Sarah, do you have any experience on proposing maybe sepsis specific guideline or task force for other OBGYN fellows or something like that? Or should you just according to the sepsis guidelines for that internationally done or whatever? What do you think?
Great question. This is something I'm very passionate about as well, actually. But yeah, it is something that I try to discuss more with my OBGYN colleagues because I would admit I myself as an OBGYN didn't recognize that like the most important thing by far when it comes to management of sepsis and septic shock is early antibiotics. And I always say, what's the first thing that we do? We run to a room when a patient's septic, we're inserting an IV, giving her fluids, getting labs. What's the last thing that we're doing? The last thing we're doing is going to computer, putting the order in for, antibiotics. It defaults to a few hours from now, pharmacy saying, oh, wrong dose, and by the time it's actually infusing in the patient's IV, it's way past an hour. So it is something that I, definitely try to educate my OBGYN colleagues the importance of, timely treatment and specifically of antibiotic administration. I also try to emphasize the importance of, broad spectrum antibiotics for especially for patients who are septic where we're not quite sure what is the etiology of it. We know that every hour of delay of antibiotics increases the patient's mortality by 10% in the first year. And so, so I would say definitely the number one thing I try to emphasize within the OB world is early antibiotics administration. And I would say this is difficult to do. I could barely check a cervix within the first hour of the patient presenting the triage, let alone trying to make sure that she has antibiotics infusing within the first hour. That's challenging to do, but I think it's important to, really educate. And, it's been shown that having like code sepsis alerts and having, for example, antibiotics in your Pyxis readily available have been shown to improve outcomes. Having it just again more readily available, less barriers to administering it to the patient.
Thank you. Last
Sure.
comments from both of you. Any comments or suggestions for us in Indonesia or specifically in Bali, maybe? Professor?
I think so thank you for the tour of the hospital. But I think that maybe what we might have to say in a place with more money and more resources and higher patient expectations might be of limited use for you here. I have to say that the maternal mortality ratio in Indonesia has declined in the last 12 years. The maternal mortality ratio in the United States has tripled. So I guess my question would be, what should you be teaching us, right? Because apparently we're not doing such a good job.
Sarah? Well, I'm not as brave as that to say that we are better. No, not yet. Sarah, what do you think? Any comments? Yeah.
Well, first off, thank you again for having me here. It was wonderful, like seeing your hospital. To be honest, I think that I would love to learn more, and I know it's hard to do in this setting right now since we're like out of time. But I would actually love, and I know Dr. Platinum feels similarly, just learn what you guys do as a norms for me to better understand, maybe some differences and where I could really pinpoint differences in management. So, but yeah, whatever it is that you guys are doing, it seems like you're doing great. As Dr. Platinum mentioned, your maternal mortality is decreasing. I think, yeah, if I just were to highlight anything that's just similarly just for top 3 or top causes for maternal mortality, it's, like hemorrhage. So like, prompt treatment, 1:1 ratio, preeclampsia, again, bringing that blood pressure down below 160/110 as fast as possible. Sepsis, giving antibiotics within the first hour. I think that would be my summary. And it seems like you guys are doing a great job of doing that.
Thank you very much. Such a great closure. So it's a wrap for us. Thank you very much. Thank you very much, Prof. Lauren. Thank you very much, Sarah, for coming to our department, for touring with me, and also having fun with me also. And I wish you a good flight to Malang, because after this you'll go and you will teach another great doctors and physicians in the Perdici in obstetric FCCS. I wish you a great and enjoyable trip also in Malang. And I would like to say thank you to the participants and very interesting questions, lots of it. I apologize that I could not bring it all to the panelists to get answer, but don't forget to stay in touch for the next webinar. for the next upcoming third ISMOAC 2024, because Sarah will be there, and hopefully Professor Lauren could also give us also some comments. And last but not least, I would give this back to Burhan as our MC. Thank you, Burhan. Thank you.
Thank you. Yeah, thank you, Dr. Sindri. And I would like to send our first gratitude to Prof. Lauren and also to Dr. Sarah. Thank you for your comments and your suggestions to our hospital here. Well, finally, we have come to our end of our this guest lecture event. We apologize if not all questions could be answered at this time. And we request for Prof. Lauren and Dr. Sarah and Dr. Sindri, please, we'd like to capture this special moment. Just make sure you look great in your camera, and our IT department will take a picture. So I will count down 3, 2, 1. Okay. Well, in the question, on behalf of this entire committee, allow me to express our gratitude to Dr. Sindri as our moderator and Prof. Lauren and Dr. Sar as our speakers for taking their time to share their knowledge, and then to also to our sponsors, Pediatric Scientific, for their support, and to all of our participants who have attended our guest lecture. We apologize if there are still some of our shortcomings in the implementation of this guest lecture, and we would like to invite our participants to attend the next webinar, which will be held online on 15 March 2024. And the link was available in the description column. Once again, I would like to inform you that the attendance link can be accessed through the link which is already available again in the description column. Of course, we hope that this event can provide valuable knowledge and insights to all of us. And see you at the next webinar. And allow me to close this guest lecture with Paramasanti. Om Santi 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 Om.
Thank you and bye-bye.
Thank you so much.
Thank you so much. Thank you.